I know Chairman Cooper was in the garage, and we'll just give everybody just one more minute and then get going. Good to see y'all this morning. Okay, I think we'll go ahead and get started. She'll be here in just a minute, and we'll catch up. It's good to see y'all. I know many of you were here for the last meeting, and it was such a good, exciting meeting. I think we got off to a great start, and I look forward to who and what we're going to hear about today. So before we do, let's just pause just a minute. I'd just like to offer a word of prayer. Dear Heavenly Father, we come to you this morning as we all rush to get here and ask that you just help us calm our hearts down, open our ears and our minds, and help us to listen to this challenge that we're facing, and help us to find creative ways to make it better. I ask that you be with us all as we travel back home and around our great state, and just take care particularly of those we are trying to serve. In your name we pray, amen. Okay, so I'm excited. Ready to hear from Dr. Constantino with Children's Healthcare of Atlanta. And either place, whether you rather stand up or sit down, and we're ready for you whenever you are.
Great. Well, thank you so much for the invitation. And I am accompanied today by Marcus Graham, who is an anchor of the clinical program at Children's Healthcare of Atlanta for youth in this category, by virtue of leading the entire core of people who he'll tell you about in a minute that are the front line in our emergency departments, and an important vantage point of observation that most of our testimony today relates to, that we have a vantage point of observation on this population of children by virtue of being the place where many of them land when they're in their behavioral crises. My name is John Constantino. I'm the Chief of Behavioral and Mental Health at Children's Healthcare of Atlanta, and a professor of psychiatry and pediatrics at the Emory University School of Medicine. In April of 2023, a distinguished panel of scientists, advocates, and child health policy experts convened by the American Enterprise Institute issued a report entitled "Why Foster Children Are Sleeping in Offices and What We Can Do About It." It concluded that the 2018 Family First Prevention Services Act, FFPSA, which was intended to protect children and adolescents from hazards of institutional care, precipitated a cascade of unintended consequences, resulting in large numbers of foster children and adolescents with higher levels of need, living in a range of inappropriate settings, including child welfare offices, emergency departments like ours, hotels, and homeless shelters. Across the United States, FFPSA resulted in severe shortages of placement options for undomiciled foster youth. So the problem wasn't only in Georgia, this is a national issue, which were precipitated through that legislation by constraints in the following: constraints in resources, constraints in qualifications for reimbursement eligibility for youth, the numbers of beds by broad extension of the Institutions for Mental Disease, IMD, exclusion in Medicaid, restricting bed capacity to 16, and for congregate care settings that could otherwise be providing compassionate, qualified, appropriate care to this vulnerable population. So following that, in April of 2023, what we decided to do in Georgia was to specify exactly what was happening to children in this category in the state of Georgia. And it's very difficult to be able to track and follow what is going on in the lives of children who are abandoned, who don't have any place to go. And I think, as many of you know, our data systems do not talk to each other in a way that in real time we can understand where have they been, what has been done, what is next, and what is working or not working for that particular child. We are all flying blind because we don't have the data that could be integrated in real time without any problem in 2025. But it's not being done. And so one of the things that we'll conclude about this has to do with getting the data together around these children to get them what they need. But what we did, and as an example of the power of this kind of data integration, is we cross-referenced data from the Department of Children and Family Services with data from our own emergency department. And I'm going to show you what that data looked like. It's all published, so this is public information. And what happened was, when we cross-referenced the information, what we found was that youth in 2023, and we took a sample of the last consecutive 150 abandoned children who had no place to go in the state of Georgia, and we cross-referenced the available Department of Family and Children's Department of Family and Children's Services data with Children's Healthcare of Atlanta data, and with whatever what DFACS had at its disposal. And to profile these youth, the average age of the youth is depicted on this slide, was 15 years of age, both for the ones who had been seen within the past 6 months in our emergency departments and those who hadn't. So we had a sample of the last 150 undomiciled youth at that time that had been in our emergency departments within the 6 months prior to their becoming abandoned, homeless, and relegated to a shelter or a hotel. Those children had been in foster care on average for the children's group for 28 months and for the rest of the group for 22 months. The number of prior placements of these children on average was 16 prior out-of-home placements. And the proportion who had juvenile justice involvement was on the order of about 40%. Now, when you think about 40% with juvenile justice involvement, you think about, well, these are tough kids with a lot of tough problems and interfacing with the legal system and so forth. But when you look under the hood, and what we were able to do is to look under the hood of the lives of these youth that had crossed our paths in our emergency room, seen by our mental health specialists, and then ultimately abandoned as a kind of a fault of our system, of the whole system. And I don't mean anybody's personal fault. I want to go back to the representative's invocation of the Creator. Like, there's an act of creation that we have to do to bring together the right services, the right time, the right data to avert these kinds of problems for youth. But down the line, for the ones who were seen by expert clinicians in the emergency department at the time before they were ultimately undomiciled, you look down the row of the column of their primary psychiatric diagnosis: depression, schizophrenia, bipolar disorder, reactive attachment disorder, post-traumatic stress disorder, disruptive mood dysregulation disorder, and you look at that list. And that's not about conduct disorder and delinquency. It's about mental health conditions that are actually treatable. Their placement recommendations by our personnel in the emergency departments, almost to a child, was that they needed some form of residential treatment, okay, for which there is not enough capacity, and it's not always the right kind. And no one would ever say that residential treatment is a panacea for all of these youth. but the right kind of residential programs that deliver the right kind of care at the right time is extremely important. And every one of these kids was recommended that kind of care, didn't get it, and ended up abandoned and in these kinds of situations. Now, in the right-hand column, you look at the additional circumstances of their lives, okay? Multiple prior psychiatric hospitalizations, parents hospitalized for cancer, HIV positive, family undomiciled, mom with schizophrenia. Patients denied psychiatric hospitalizations because they were too acute for the conditions that they had. Parents and close relatives, whole families devastated by severe persistent mental illnesses, oftentimes which are no one's fault. They're inherited conditions that run in families and that these children were the heirs of. Children who were minimally verbal, moms and dads deceased, children who with very severe manifestations of psychiatric conditions, and some not enrolled in school, malnourished, with parents in the correction system. So these are the profiles, to paint a picture of who these children are and what they need. And when there aren't enough appropriate places in the system, when they have these high levels of needs, which we don't have, over 40% of our beds for residential psychiatric care in the state of Georgia are occupied by non-Georgians. Okay, they are made available to out-of-state kids, and we trade kids with other states, so some of our kids go out of state because there's no place in state for them. They go away from their families. And this particular horse trading of kids, because when they move from one state to another, they command a higher rate for the facility, is something that we have the power to stop and to revise, because that kind of activity is disruptive, it fragments care, and again results in this situation, which is a depiction of all the kids in the community who, in any given year, there's 45,000 kids in the state of Georgia every year, if you think of a generation, that need some form of significant mental health treatment. And if they don't get it, they're going to fall into the safety net. Like that's the kind of state of things. And we have major gaps in our treatment, paradigm in the ecosystem in Georgia. But there's opportunities in primary care, outpatient specialty care, crisis intervention, and so forth. And when there's gaps, children fall through these gaps. And when, on the severe end in this diagram, they fall through the gaps because there isn't enough high-end intensive care for these kind of problems, they cycle right back to all of these other places in our system. And so there are data, from administrative databases that show that these gaps are real. This is a state of Georgia, or a University of Georgia study that showed essentially that 34% of the actual demand for the real need for Medicaid-insured children in Georgia was completely unmet. We see this in our emergency room every day. Among the over 2,000 children discharged from the emergency department during a 9-month surveillance period recently, 12% of the kids had recurrent visits even within that 9-month period for behavioral crises. And among those, 20% were documented by our frontline workers that Marcus leads, that they never had received services before for mental health conditions, and they came back and never got what was recommended to them when they left the emergency room in the first place. 60% of the time, when our patients are discharged to the community with needs for mental health services, they don't get any, and we don't see that they've had any at 30 to 75 days following an emergency room crisis visit. So Marcus is going to say a few words about this particular population, and then we'll wrap up with some recommendations.
All right. Hello, all. And again, my name is Marcus Graham. I manage the behavioral mental health clinicians that work across the 3 emergency departments at Children's Healthcare of Atlanta. So it is my team that's responsible for completing these assessments for the patients that are presenting to the emergency department to try to determine the disposition for each patient. So to speak a little bit more about the abandonment, we have had for this 2025 year, we've had hundreds of patients that have came through the Children's Healthcare doors that linger in the emergency department because there was no place to send them to get treatment at these crisis stabilization units. And most often, the denying reason is most often due to no bed availability or high acuity, meaning the patient's behaviors are too high for these CSUs to manage. We also have had situations where a parent may bring in their kid and the patient may not typically meet 1013 criteria because they're not an imminent danger to self or others, or there's no psychosis going on, but the patient is presented with some type of disruptive or behavior concern or some form of aggression, but again, not to the point where it warrants a 1013. So in 20 situations this year, we had parents just straight out say, I want to relinquish my rights because they don't feel supported, that there are services out there in the community to help them manage their child behaviors and mental health concerns. With these patients presenting in these situations, this is where the clinicians are having to get the Department of Family and Church and Services involved to come in to try to help determine a safe discharge plan. And over 40% of those kids end up being placed into the custody of the Department of Family, Church, and Services if the Department of Family, Church, and Services are unable to find a relative or kinship placement for the child. And one of the common factors is that every single one of these kids that presented to the ED where the parents wanted to relinquish their rights, these patients had some type of defiant or disruptive behaviors in the home. And to give a real life example, on Friday night last week, we had a 14-year-old female that presented to Hugh Spalding Emergency Department. This was her 6th visit to Children's Healthcare Emergency Department for a behavior concern. Outside of presenting to CHOA, she also presented to other hospital emergency departments 12 times this year, so that's a total of 18 emergency department visits due to her being in a behavior crisis. This patient actually presented with self-injurious behaviors, cutting her wrist, ingestion of Lysol to attempt to end her life. There was also some history of defiance in the home and defiance in the school system. Mom was on the verge of wanting to relinquish her rights. However, the clinician was able to talk with mom. Mom states that she's overwhelmed. However, she decided she would not relinquish her rights in that case, but she would continue to go along with us placing the patient on a 1013. However, this patient has been placed 18 times at an acute psychiatric hospital, but has yet to be placed in the PRTF program because she wasn't either approved or there was no space for this patient to be admitted to one of the partial hospitalization programs. And just to give a little background, in the emergency department at Children's Healthcare of Atlanta, the behavioral team serves about 5,000 patients per year on average. As of yesterday, we were at 3,800, so we're going to definitely surpass that 5,000 number. But out of those patients that we assess, about 50% of those individuals that did not have any prior mental health outpatient treatment. They use the emergency department as their form of treatment and will bring the child directly to the emergency department to seek mental health and behavior services. And more often than not, the parent are saying that they don't have the resources or means to get these individuals the proper care that they need. And The payer source, just to speak about insurance, 47% of the patients that did present to the emergency department that had straight Medicaid and was placed on a 1013, 47% of those kids were left in the emergency department with difficulty finding placement. So we're there seeing the patients every single day, completing reassessments, trying to determine what can we do since these patients are being denied from these acute hospitals. What can we do to improve this patient's care? So oftentimes we're just continuing to reassess, continue to call these CSUs to try to do a doc-to-doc conversation to try to get them admitted. Sometimes we work with DBHDD and their insurance to try to get them an acceptance across state lines.
Thanks, Marcus. So, last two slides. The first is a depiction of one of the places where Children's Healthcare of Atlanta has started to try to strategically target some of the gaps that are part of this cycle that occurs, and particularly leveraging our position as front line for behavioral crises, especially when a child comes in for the first time in a behavioral crisis. And as Marcus alluded to, very often these children have never had any mental health care before. How do we begin the process of recovery from the day that they leave the emergency department so that they don't have to come back? And this has been a very successful point of intervention. It's not the only one. We can go far upstream, and we also, again, have to go downstream to the place where these very high-end kids need the appropriate kinds of opportunities for care. But in this particular node, when they land in the emergency department, they are discharged to the community, and otherwise 60% of the time they would get no services within the next month or two. We have concentrated a recovery program, a crisis recovery program for youth at Children's. And what has happened as a result of that is, to make a long story short, the proportion of children who are presenting in crisis that get hospitalized is coming down. The physicians and the people of our emergency departments are redirecting those children from hospitalizations into appropriate outpatient care. We're able to deliver crisis recovery outpatient care at this point to about 1,500 kids per year based on the resources that we have, and it definitely costs more than insurance pays for, but we're able to deliver great care to this population, and the result of that has been essentially a 60% reduction in recidivism of a crisis in the emergency room if they just get the evidence-based care that they need when they leave the emergency department. It's been an overwhelming success, and what we want to do is perpetuate that success in other nodes of the system where we need to close these kinds of gaps. So the recommendations that I would make to the committee are these. First of all, the number of high-quality psychiatric residential treatment facility beds for Georgia children just has to increase. There are more kids that need this level of service. And again, this is not to warehouse children in residential facilities. This is to treat them for the conditions that we tried to articulate in this report in terms of what are the actual mental health conditions that they have that are treatable. Second, Georgia should substantially amplify the availability of therapeutic foster home capacity, because therapeutic foster homes in certain ways function like residential treatment facilities when it is possible for a well-trained, well-equipped family to actually support a child who would otherwise, as Marcus alluded to, whose families just say, I can't do this, I don't have the resources to do it, I don't have the know-how to help my son or daughter. And then finally, all providers participating in governmentally supported mental health services. So this means DBHDD, DFACS, DJJ, DCH. When our government agencies are contributing to care and interacting with a health system that is taking care of the health needs and mental health needs of these kids, we need real-time access to each other's information. When and how many times were they placed out of home, or did they touch the other system? what interventions were actually delivered or are being delivered to those patients in real time. Are they working? Are they not working? Did they get completed or did they not get completed? That's the kind of data that we need to share, and everybody needs to understand each other's data because we're all flying blind in the dark in real time, caring for these patients without that kind of information. So bringing that together, which it's been envisioned, but it's just never yet been fulfilled for the children of Georgia. I think we can do it. The technology exists to do it. It requires will to do it. And lack of that data is literally plaguing accountability for care, quality monitoring, and really appropriate treatment planning for these children. They could be receiving much more efficient care if we knew what was going on and what was working and not working. So I'll stop there. We're happy to entertain questions and really appreciate the opportunity to present to the committee today.
Thank you, Dr. Constantino, and thank you for this great handout that we will work from too as we develop some recommendations. Your recommendations, I personally feel, are very spot on in their conversations that we have with all of these agencies every year that I have been here. So I'm hoping that the push and the creative work that y'all are doing too to try to deal with the problem can help us move forward. We do have a couple of questions here. I'll start with Dr. Hawkins.
Yeah, thank you for your presentation. I've got a question about bottom of page 4. You're talking about straight Medicaid versus Medicaid CMO. So are we talking about LIM versus ABD, or could you explain that?
So these are the children's primary providers of medical insurance.
Right.
And so when they're the children who are on fee-for-service or straight Medicaid are typically children who are either deemed permanently and totally disabled or have qualifying health or developmental conditions. And
that's ABD then you're talking about.
Yeah, and then the rest are the ones who are commercial managed Medicare, Medicaid for essentially for low income families.
Okay, so my understanding is that our state's made a decision to move ABD slowly into the CMO world and leave fee for service. So I assume by looking at these numbers, you're talking about 75% of your denials are related to Medicaid. Is that right?
Well, so there's a higher proportion of denials for those children. They're much more involved on average in terms of their needs and so forth. And so thinking about a child who has been deemed permanently and totally disabled on the basis of autism or schizophrenia or a variety of really very high-end conditions results in the facility saying, we don't know if we can take that person again, or quite often saying, this needs a different level of care than a 5-day acute hospitalization, because usually these hospitalizations really are only on average 3 to 7 days in length. And the facilities will say, look, why would we start a 5-day intervention when we really need a 3-month intervention or a 4-month intervention to really reset what's going on for these children?
Well, I guess my other question is, a lot of times in the medical world, you treat the patient and then you find out on the back end you're not getting paid.
Yeah.
Because it's an immediate need. And
right.
It sounds like you're dealing with a lot of immediate needs, so you're treating the patient to a point and then finding out you're not going to be reimbursed.
That also happens. I mean, right. And honestly, what Marcus referred to as 1013, these are children who are at imminent risk. Right. These are life versus death situations right. for these patients.
So they're being brought in by deputy sheriffs and police and all the fire department stuff. Yeah. Okay. Is there any way you got any suggestions that we could help you in this area?
Well, I think this is all part of this same problem. In other words, this backlog, when we don't have enough to keep patients who need higher end care and get them to the right kind of care, they're going to keep coming back. This is why Marcus is saying, like, this last kid had been in 18 different short-term situations, none of which were working, all of which cost something, and were not the right kind of care for what she was being recommended. And so we have to take care of the high end, and at the same time we have to also get upstream, which we're trying to do even after their first crisis, so that we can prevent them from ending up back in the emergency department or even needing that higher level of care. Sure. And we're having a lot of success at that. but there just needs to be more of it.
Thank you.
Yeah.
Representative Cameron.
Thank you, Madam Chairman. Thank you, sir, for the information you provided today. I'm just trying to get my head around, and you talk about databases don't communicate, and that's a problem. I was in the health insurance industry, so I totally get it. Do we have any idea in Georgia how many children who are treated for mental health are actually abandoned? I mean,
it's hard to know that, because at any given point in time, the Department of Family and Children's Services has its set of kids that they're dealing with. And the juvenile justice system has its set of kids that they're dealing with. And the hospitals and emergency rooms have their set of kids. And there's kids in each of these systems.
so the lack of coordination causes
Yeah.
no one really knows.
There is not active data sharing. There really isn't a way in real time to coordinate information about who all is touching this child and involved with this child. I mean, if you do a lot of digging and a lot of calling and a lot of, surveillance, you can kind of catch up with what's going on with them. But in terms of actual bringing the data together for a clinician who is trying to decide, or an agency that's trying to decide what's the right next thing, we don't have that kind of information at our fingertips. And it all should be shareable. It's all government data.
Well, and like if you had one database at the sheriff's department, put someone in, and Family and Children's Services had the same one, if they knew those two they would actually know the person and their history.
Right. There are ways to cross-reference the identifiers, link the identifiers and all that, but it's just not done in a way that is functional or facile on the ground for these patients. And then even in the long term, if you want to ask a simple question of, if DFACS changed its practices, if somehow we were able to solve this problem of this 40% capacity for psychiatric residential treatment that's going to out-of-state kids that could be converted to in-state kids, if we wanted to know what was the impact on our system for out-of-home placements for DFACS and kids ending up in the delinquency or juvenile system or in the safety net, we don't share enough data to actually know whether moving a lever in one place is changing what's happening in another place. And that's part of flying blind. And I think everyone deserves to know that when these Herculean efforts are made to increase capacity or to implement an innovation, let's get the data together so that we know it's moving the needle in these other places that are the real indicators of the well-being or lack thereof of children in our system. And I think we can do it, but we've really got to bring the data together. And like I said, you're seeing an example from a crude, simple, one-on-one merging of data of the health system and the Department of Family and Children's Services. What if we were all sharing data like that in real time for the major elements of care that we need to understand in order to make the right decisions for kids?
Okay, thank you for your answer. Thank you, Madam Chairman.
Thank you for the question and for the answer. It's a challenge that we have talked about and pushed for years. You might just be helping us get there. Chairman Cooper.
Thank you, Madam Chair. I have several questions. Because this is a subject near and dear to my heart, the lobbyists may already have warned you about me. I'm the one that's asked everybody connected, except you, and now I have a chance to ask it, is that you've made a lot of progress, and I'm very thankful and have been since you opened up the outpatient care department. I'm so appreciative of that department. But children's health care really leads the way in Georgia for health care for children in all areas. And I think that we need an inpatient unit at children's health care to lead the way to other hospitals that they can do it and what works and what doesn't. I mean, even 6 weeks, would be a help with some of these children, and being able to talk to their parents. When people have said, "What about the money?" as you see, the top person, the lady that runs everything over there, said to me, well, I listen to my doctors about what they want, and then everybody else says, oh, it's all about the money. And my response is, take some of that $1 billion out of the savings and go steal from every state that the doctors we need and the nurses we need. I'm a nurse, master's level. Psychiatric nursing is my area of expertise, and so that's why I'm so passionate about it. And I want to, once again, thank you for all you do, but if we're totally responsible for treating all patients and the care they need, it seems like we need that other step at Children's. So I got my plug in. The other thing I want to know is, what are you doing, this new program that you were saying helps, that you've started? So what is it? You see them after they leave and you see their families, or what happens and how long do you do it?
Sure. Okay, so Representative Cooper, thanks so much for the questions. These are great questions, and let me begin this way. I'm a native St. Louisan,
Yeah.
and I moved to Georgia from Missouri just a little over 3 years ago,
Right.
because I think what has been created through Children's Healthcare of Atlanta and the state of Georgia through the downstream of House Bill 1013 and the parity kind of posture of the state, that there's no better place in the United States to change mental health care for children than this state. And when I began here, I took a page out of our old playbook in St. Louis, because one of the issues was that when we or our neighbors in Cincinnati built hospitals as a antidote to the child mental health crisis, what happens is those hospitals are only helping them for 7 days.
Yeah,
Okay,
yeah,
and that does not recover them. So I'm going to answer your question in 3 ways. First of all, we began when I first got here by building a workforce. We need more people to actually deliver, and we have now 150 new clinicians brought into full-time into the workforce for children's mental health, just as a start. Okay, we opened our doors at our outpatient program about 1.5 years ago, or 2 years ago, and there is a strategy for building that workforce. It's mostly new grads. It's attracting them into the field. It's bringing people who wouldn't otherwise accept insurance or accept Medicaid to be part of a program that took care of all children that came, through the door and so forth. And that there's a strategy for that, and that is working. We built the outpatient care because if you hospitalize a kid, and 60% of the time there's nothing after the hospital or after the ER crisis, like all you're doing is stirring up the same problem. So we built this outpatient capacity. I'll describe it in a second in more detail. Then the other thing that we were looking at was comparing ourselves in Georgia to the backlog of kids who end up in the emergency rooms because there aren't enough inpatient places for them. And Marcus is right. There's a lot of denials, and we need the right kinds of places. But currently, our average in terms of the time of a kid that is boarding in our emergency department with a mental health condition for all comers is only 12 hours. It's days in many other major cities. So what we decided to do was to concentrate on true recovery care. So that's the second thing I want to say. The third thing is that I assure you that the institution is carefully considering, I'll say that for now,
Okay.
the addition of an environment that would be a model for inpatient related psychiatric care. And I promise you that our institution is very, very carefully considering what is the right type that will help to set an example and a model for the community and deliver the kind of care that we all aspire to for that level of care. This is something that we did in St. Louis and modeled it at St. Louis Children's Hospital. And the downstream of that was the community said, oh, like this is really what we want. And then the community syndicated it. And in a step that's actually happening in real time right now. I think that can happen in Atlanta as well. So in another forum and another day, I'm happy to share with you and talk about that. But the last thing I want to say is about the program itself, about the outpatient program. And I want to remind you that this outpatient program is preventing the same hospitalizations that you're invoking, building more hospitalization, capacity for. Granted, we want it to be high quality. Granted that Children's wants to, help establish a standard. And we are working very closely with our partners in the community to make sure that the standards for that kind of care are rising in Atlanta. And I believe that they are starting to, based on where we were when I first got here. But the way that the program works is after a child leaves the emergency department, we say, what do they need in order to recover? So it is an intensive outpatient program that includes family, crisis intervention, as many times over the ensuing months that a kid needs to come in, as frequently as they need care. And specifically, the program that I described here is very highly targeted towards suicidal youth who comprise about half of all of our emergency crisis visits that Marcus described. And we use dialectical behavioral therapy-based intervention, which is the true state of the art for recovery from suicidality. When I came to Georgia in 2022, I asked around how many dialectical behavioral therapy therapists would take Medicaid, would accept Medicaid on an outpatient basis, and the answer was 0, okay? So what we decided to do is we're going to attract a core of DBT-trained therapists to take care of this population of kids. We have a dozen full-time DBT therapists that take all comers of kids, and we know exactly what we needed to pay them to attract them into the workforce, to sustain them, to train them, and to deliver care that has this kind of outcome. So we can help to, sort of inform what it would take to syndicate this kind of care in this node of the care continuum.
Madam Chair, can I? Thank you. Can I go ahead and?
Sure.
Okay. Thank you. See, I knew if Children's got started that y'all could bring the people here. I mean, the lobbyists will tell you, I've been on at this for several years now, begging. And like I say, Children's is our leader. Where did you get these people? I mean, one of the problems that we have in Georgia, for every group that delivers mental health care, our CBSs and all these groups, the crisis intervention, they're short of help, of trained and the correct things. Where did you get? Was it social workers and psychologists and these specially trained and the doctors? How did you have to get them all from out of state? I mean,
great question. So the first thing I did was I promised the community that we would not use our $1 billion endowment, our $500 million endowment, to steal therapists from the rest of the community. Okay, I promised everybody that we would not do that because that's a zero-sum game, and everybody was afraid. You got more money, you can do that.
Right.
So we grew them up. They all came out of training. It is a young core that was brought in, and there are a lot of agencies around town that will take new grads. And the problem is when the new grads get fully certified and licensed, then they can command a higher salary. It outstrips what insurance will pay, and then they leave the insurance pool. That is the shame of our field. Okay, that's what goes on, and that it's possible. I mean, we don't do that for people who prescribe insulin for diabetes or who treat cancer. They don't leave the insurance pool. Okay, but in mental health, they leave the insurance pool. And so what we did was we calibrated what it would take to create meaningful, great careers for them, okay? Pay them adequately, make sure that they are in a structure that supports them and that they're able to see the difference of their own work, okay? Now, what happened is that we are still losing money over and above what insurance returns, but it's not as much as everybody would think, and I think it is completely manageable to syndicate this kind of care. Another kind of care that we've started to syndicate is the work of nurse practitioners. When I started in child and adolescent psychiatry, it was predicted that there would be a huge shortage, a terrible shortage of child psychiatrists, and that has come to pass. Child psychiatry shortages are universal in the United States. We could solve them in the state of Georgia with nurse practitioners, psychiatric mental health nurse practitioners, because we have modeled at Children's how you can supplement a core of child psychiatrists with nurse practitioners And the nurse practitioners, even though they are taking all comers, including commercial or CMO Medicaid, are this close from breaking even. That means that they're totally scalable. We could end the 30-year child and adolescent psychiatric shortage. So we're working on these things from the health system perspective to try to contribute to the system. And what we want to do is link what we're doing at the nodes where the health system has its role with where the schools, the primary care sites, and the community service agencies are working hand in hand. And when we take care of patients, we are constantly knocking on the door of our partners because we don't want to build anything to compete with the community. We just want to build what the health system can do to supplement what the community needs.
I think that you brought up a problem that we need to look at, Madam Chair, is when you're talking about nurse practitioners to the members, we're not talking about a regular nurse practitioner. We're talking one trained in psychiatric care.
Correct.
And unless it's changed in the last year or two, there are not a lot of nurse practitioners.
It's changed.
The
nursing schools are graduating more of them, including Emory. There are philanthropically supported workforce pathways that are being supplemented. And at any given time, I have 20 CVs of psychiatric mental health nurse practitioners on my desk that want to come and work with this team. We don't have enough slots for all the ones that are actually available. So
Good.
My point is that I think that we can fill the ranks. I think that there is a available workforce that could be attracted to do this work. And again, child psychiatry is not the only field that's relevant here. Psychology is relevant, social work is relevant, but there has been a 30-year shortage nationally of child and adolescent psychiatrists, and if we had the will to do it, I think that we can solve it here in Georgia in pretty short order.
Okay, the only thing I would like to say is, and maybe there's one and I don't know about it, but in child endangerment, we have in each district of the state, we have a place where the district attorney for that area and everybody that's related to child abuse comes together on a regular basis and meets, and they found that very helpful. Sounds like we need something like that, maybe led by Children's Health Care and maybe yourself, to come together with all the providers to know where we are, know what's going on, know what the needs are, and specific, because it's really worked
it actually
with child abuse.
It actually works just like what we're talking about today. So there's a front end to a child abuse foster care career of a child. And following the very first time a young child is placed in the child welfare system, if you organize the right kind of two-generation mental health support and reunify those families with that kind of support, we proved in a 10-year program in St. Louis involving 400 young children in the foster care system that you could reduce the likelihood that they ever came back into the system over 10 years sixfold, okay? Like, we have methods, but again, to bring all of those services together in a dedicated reunification support plan and strategy, which is similar to what the state is starting to do in its Safe Baby Court program and its Infant Toddler Court program. So we're really trying to work with partners in the community that are championing that cause. But we could reduce the total number of kids that are in care like this if we're taking care of young families and supporting them to be reunified safely and with the right kind of services to help parents function and manage, kids who will otherwise end up in this abandonment pool. It's really an exciting opportunity, and it's way on the front end, especially for young children in the system.
Well, Madam Chair, the last thing I'll say, and I won't ask questions with other people, is that I hopefully there's hope on the way from the Medicaid system. The head of the whole Medicaid system in our state testified last time, said that all of the CMOs that are going to treat children here, cover them with Medicaid in the state, have agreed to come up with treatment plans where you would have a continuity of care and it wouldn't just be dropped off and that not a follow-up or only 7 days of it, that there would be a medium length of care, and then also the longer care. My only thought is, where they're getting the staff, but they have agreed to do that and to pay for it and to pay for families also have care on the side, which, if they do what they told us in the last meeting, would be miraculous. And I think in the care and what you're saying needs to be done, I think the only glitch is if they can find good providers and places to provide that
Sure.
care.
Well, and we want to be supportive of that. So in other words, we want to be agents of making that a reality. So in this program that I showed you today, the model of care is such that children are not discharged from this care until they're better. And the clinician's job is to develop a treatment plan where no stone is left unturned in the evidence base of the field. We hold ourselves accountable to that level of follow through with a treatment plan, and these are the results that we get. And what we can also do, and we are doing, that may help with this, is that for the kids who aren't yet in this kind of model of care, and that we must depend on the community for the whole population of Georgia's children, we all have to work together. But any of the 500,000 children who touch Children's Healthcare of Atlanta, we have revised our electronic health record system so that if those children end up in the emergency department or in any aspect of our behavioral and mental health program where we expect those kinds of treatment plans to be completed, we are monitoring within the health system whether or not that's actually happening. So we can actually be an agent of helping the insurance companies just to make sure that if that's what they are planning on doing, and that is what they're saying that they're doing with a patient, if we touch that patient, that we can track whether that is actually happening to a patient with a mental health condition that's enrolled in one of our programs in behavior and mental health at Children's. And we will continue to track and share that, the experience of that so that we can point out where those gaps are and how well they're doing with that. Right now, that is not happening. Based on everything we have robust information about, where those drop-offs occur, where those shortages in workforce are, where there is inadequate networks within the insurance provider community to actually respond to the needs of the kids. And we have that information auditable within our electronic health records for the children whom we're caring for and treatment planning. So we can help with this, and we want to be partners in this and help the insurance companies know where some of the most important gaps to be filled will have the highest impact on the population.
Thank you so much, and to not only you, but to all the staff that makes what you see as our future in helping children become a reality. I can't thank you enough, and it gives me hope that we will see major changes in how we help children with mental health problems. Thank you. Thank you, Madam Chair, for putting up with me. Thank you.
Thank you. Great questions. Representative Crawford.
Thank you, Madam Chair, and thank you to you both for your presentation. I have a few questions, and they're kind of one within the same, if I may. The first question is, during your presentation, you mentioned there were about 60% of kids who may present to healthcare facilities but may not immediately receive the mental health care that they need. And we talked about the different dispositions and circumstances of why they present. Is there any data to show which kids are not receiving the needs that they need immediately, and breakdown? Can we see like a breakdown of who's not receiving the needs so that we can maybe target?
Absolutely. We have that information, and it's essentially in review right now for publication, but it should be out relatively soon. And we can profile what the needs are and the unmet needs literally by evidence-based treatment modality. Like, was this child supposed to have cognitive behavioral therapy? Was that child supposed to have dialectical behavioral therapy? Was that child supposed to have a psychiatric follow-up, or whatever they need, a crisis intervention or in-home support? And so we track and are able to, in real time, provide that kind of information on the basis of what's auditable in our electronic health record. So we have all that data. We have a new modality within Epic, within the electronic health record, that specifies these bits of information in discrete fields. So what was recommended for that child? Did they get it or did they not get it? And if they didn't get it, why didn't they get it? What was happening? And so all that information is now available automatically for thousands of kids who are coming through our program. And we're still, refining the data collection and interpretation. There's, a lot of it's based on young clinicians that are, checking the right box in the record and so forth. But they're training up and they're understanding that they're part of devising a solution here. So that information is being gathered.
Thank you for that. And I would assume that my next question will probably have the same response. You talked about the 60% behavioral recidivism rate, and that's incredible. But the question that I have is almost the same. Is there any type of data or markdown where we can show which type of services are being met more frequently? Which ones do we need to address more?
Yeah.
Okay.
Yeah. I mean, I think some of the most common services that are really missing, just to put it out on the table, is dialectical behavior therapy, cognitive behavioral therapy, intensive outpatient, paradigms for kids that need to be seen not weekly but like every day for some short period of time. And there are all indications for this. There are clear indications of when this should happen and when that should happen and when that should happen. And there's just not enough. There aren't enough providers in the networks to deliver those interventions when they need to be delivered, especially for children in crisis. And Representative, one of the things that I'll point out is that the 60% number is if you come into an emergency room in a behavioral crisis, and then you go back out to the community in care as usual, the way it all works out, 60% of the time, what's recommended after that crisis by a physician in the emergency department is not happening, okay, on outpatient. And these are kids who are safe enough to discharge but really need help. And if they don't get help, they're going to come back. And the recidivism rates are considerable for these children, depending on whether you can take the 60-day, 90-day, whatever you want. But like I said, that recidivism is cut by, into less than half if you just deliver the service that's recommended by the physician or the evaluator that's in the emergency department.
Thank you. Thank you, Madam Chair.
Representative Oliver.
Thank you, sir, very much for being here today. I want to briefly follow up on Chairman Cooper's question. For over several decades, CHOA has said no to residential psychiatric care for children. I'm very grateful to you personally that no has turned into a maybe. But I want you to know that we're watching your answer very carefully on that, and we're very hopeful that your leadership is going to allow CHOA, as the leader of children's health care in Georgia, to step forward on residential care.
Well, Representative Oliver, we really believe in that. Now, I would say that it's very important to distinguish acute hospitalization from residential care also. And I think we need both. We have terrific examples of great residential care in the community that's not necessarily available to everybody, but we know what it takes to stand up really excellent residential care and have some examples of that. It's just not enough of that in the community.
You know better than we do, and I appreciate that leadership. In relation to the 150 children that you reference in your first slide, I wasn't clear. Are those 150 that you've drilled down on in defects care now or not in defects care now?
So so if you took in June of 2023, we went to those figures and tables are in a publication that was jointly co-authored by myself, our team, and Commissioner Brose. Commissioner Brose is the first author on that article. And what DFACS did was say, okay, in June of 23, if we look back at the most recent 150 kids that were, so it was a consecutive series. They weren't selected or ascertained with any kind of bias. It was just, let's take the last 150 kids that were either overnighted in offices or in hotels in the state of Georgia. That was the group that we took. And then we looked at whether or not they had been in the emergency department within 6 months prior. Because I felt like, from a standpoint of, Children's Health Care of Atlanta was touching these children within the 6 months before they became homeless, undomiciled, okay? And we wanted to understand, well, what were we seeing? What were we saying? What did we think was going to happen to these kids when they actually left the emergency department? And that's what we found. But that was the group that we took. And then DFACS got other data around them from state administrative data to fill in some of the blanks of what characterized those children.
So those were all 150 were DFACS children.
They were DFACS kids, and they were undomiciled at the time.
And what my next question, which y'all may have gone over at your past hearing, and I apologize for missing that. In the last 3 years, there's been an intensive drill down to raise the reimbursement rate by contract or special agreement with certain residential psychiatric care facilities. My memory might not be correct, but Tennessee was paying $600 plus per day. Georgia was paying $400 plus per day. Have we corrected that?
So it's been partially corrected, but not high enough to really substantively change the out-of-state swap situation.
That's my question.
They're still taking the same, to my knowledge, and the last data that I had on this was probably from late 23. So I haven't seen updated figures, but I have not heard that there has been much migration of that proportion of our Georgia PRTF beds that are occupied by out-of-state kids. And that's part of the thing that we don't have the data.
I've heard it's improved a little, but
Yeah.
Madam Chair, there may be others that have more current data on that, because that's 3-year-old data what I'm referencing.
Right. Yeah, we are still seeing major constraints, and I do not know that how much that needle has moved, and I would defer to those who are holding the data, which I am not, on that. And it's very difficult to get. Actually, if you do a search, for that statistic, all the search engines will say that data is not available. So it's very difficult to turn that up. So, and I understand, because what are these agencies supposed to do? They have to survive. They want to provide higher care. If they get more, per diems for their patients, they can cut less corners, all that kind of stuff. But, I think we all got to get serious about how
Reimbursement rates been our number one priority for several years. We've done hundreds of millions of dollars that has now been approved by CMS, and at some point this fall, maybe we'll get an update on the implementation status of those reimbursement rates and what the impact might be. You folks may know better than I do.
And it's a threshold effect. You can almost get there, but if it just isn't enough to change the decision point or the inflection point of where it makes sense for an agency, you can be very, very close, but not all the way there, and then the things, it's not going to move.
Well, I'd like to have some further information about that and what will make it move.
Right.
Thank
Great.
you. Thank you, Madam Chair.
Excellent. Are there any other questions or comments? Anyone? I don't want you to feel we've got some pretty great answers over there, so I don't want anyone to miss asking something. If you have anything. Not seeing any. Dr. Constantino and Mr. Graham, I want to thank y'all not only for being here and enlightening us today, but also for the work that you do every day and for the heartfelt work that has shown that you are trying to help us tackle this problem, because no child should have to go through it, no family should have to go through it. So I think we're all in it together. If we do have more questions, we'll be in touch, but you've given us some great information to work from and also some real services to be proud of. I have one thing I want to ask, though. I've thought about this because you mentioned your young workforce.
Yes.
That's great. That's wonderful. How are they doing with the intense burnout that comes, particularly in this?
It's definitely an issue, and I think this is what a lot of folks don't understand, is that you have to protect them, and it costs something to protect them. You have to mentor them. They become exhausted. The 12 people that work on this suicide recovery program, imagine day in and day out, your life is holding in your hands arbitration of whether or not when your session ends, is that going to be a kid that is going to, have slipped a little bit further and then end their life? And that's what's in your hands day in and day out. And this group is very supportive. We take very good care of them. And I don't mean in a luxurious way. I mean in a way that maintains their mental health, that allows them to do the work, and that keeps them in the game. We've had almost zero turnover of this group. Now, we're young. It's only been a couple of years. But our clinicians are not turning over. And, they're part of something that they believe in, and they know that their careers are oriented towards a population, not the privileged few, but children and families who really need their help. And I think this is what's sustaining them. But do we deal with burnout issues? Do I lay awake at night thinking, is this just too much for the team and for these young people? Yes, I do. But so far, we're navigating. So, and we'll continue, and we'll share the experiences that we have of what's succeeding in that realm.
Well, thank you for the energy and passion you are pouring into them. Appreciate it so much.
Well, this has been a privilege, and I also want to thank the rest of my partners that are in the room. We probably over-prevailed on our share of the time here, but I really appreciate the opportunity, and I appreciate all the work of our partners in the community, too. We're all in this together, so thank you.
Thank you. Yeah. Thank you. Okay, next, we will hear from Safe Families for Children, Abel Ortiz. And Mr. Ortiz, whichever place you would like to be sitting or standing. And I happen to know a little bit about you, but everybody else might not. So why don't you tell us a little bit before you jump in?
Okay. How do I get my presentation up?
Amber's on the way.
Okay. All right. Well, while she's doing that, Georgia's near and dear to my heart. I spent several years here working for Governor Perdue as his senior policy advisor on health and human services. And in fact, you were talking about nurse practitioners. I was one of the people that helped him draft the legislation that got them independent practice. I was also here when we started the CMOs, and when we divided behavioral health and disabilities from DHS. And so Georgia is a place that I actually hold dear in my heart. And so when I had an opportunity to work with Safe Families here in Georgia, we jumped at it. And Safe Families in Georgia has only been going since with services since the beginning of the year. And we're funded by seed money from CareSource, the CMO, and by a grant from the Kellogg Foundation for 0 to 3. But I want to start by setting some context with Safe Families and what we heard from the doctor from CHOA and the kind of the system that happens with families. And because Safe Families does focus on families. As you heard the doctor talk about the kids in high-end care and their multiple entries and their diagnoses, behind that child is a family that in some cases has walked away, in some cases are still involved. Safe Families focuses on that family. Because no matter whether they're in a psychiatric hospitalization, psychiatric residential, therapeutic foster care, or basic foster care, there needs to be a place for them to go when services are over. There needs to be a family that's involved with them during those services. When you look at residential care and psychiatric hospitalization and the repeat visits, many times it goes back to the hopelessness of the child. If you're in a residential or if you're in a psychiatric hospital and there's no place for you to go, and you know that, and your parents have stopped visiting you, what's your hope? What can you control? The only thing they can control is their own behavior. And they do that on a daily basis, and unfortunately it's often in a negative way. So what Safe Families wants to, what our approach is let's focus on working with the parents to keep the parents involved in their children's lives. And the parents can be kin, victim kin, or the biological parents of the child. So at Safe Families, what our goal is to keep families intact. And Georgia has child welfare issues on the deep end and on the front end. Safe Families can work at both ends. And so I want to talk to you about how we do that today. First, I want to give you just a little brief background of Safe Families. We're national, an evidence-based program. We're in 36 states. We are statewide in Oregon, Kansas, Illinois, and Florida because we have contracts with the state. In the other states that we're in, we have smaller contracts and we're all privately funded. We are an evidence-based program. Our primary goal is to keep kids out of home care and to keep families together. What we do is we actually surround families with a compassionate group of individuals to support them. We work primarily through churches, and we recruit volunteers that do two roles: respite care, which we call hosting, and parent mentoring, which we call family friending. And these are people that are volunteers from the community that are supported by master's level social workers to build family-like relationships with parents whose kids are about to enter foster care, or parents whose kids are in foster care who need reunification. And our goal is to keep them from falling through the safety net that's been provided for them. We were founded in 2003. We are an evidence-based practice. We had a randomized control trial completed in 2019 that involved almost 400 children and 250 families, all referred from CPS in Illinois. And what that randomized control trial showed is that we kept kids out of foster care 78% of the time, versus only 60% of the time from treatment as usual. And we also had, those kids were also still in their home 70% of the time a year later, versus 40% with treatment as usual. So we are on the California Clearinghouse of Child Welfare Evidence-Based Practices, and we are also now Family First approved. So we have gone through the rigor of getting approval for Family First, and so we can now be eligible to receive reimbursement from 4E funding from Family First. So why does this matter? This matters because Safe Families, Georgia is facing a crisis in high-cost institutional care, and because there's a lack of safe alternatives. Also, it matters because what Safe Families offers is foster care prevention through volunteer-supported programs. What we do is we work with families in crisis. So we get referrals from Children's Healthcare of Atlanta. We get referrals from DFACS. We get referrals from other hospitals, from the police department, from homeless shelters. What they call us is when families are in crisis, they might be homeless, have no place to go. Parents might need to go to social detox or medical detox, but they have children, but there's never been an allegation of abuse or neglect. We get referrals from parents themselves who hear about us. We get referrals from doctors. Our goal is to step in and create a safety net for that parent so that they have somebody that can walk alongside them, help them figure out housing, transportation, mental and behavioral health care, and help them access Medicaid services that they may not have the capacity to access because they need daycare, they need transportation, or they just don't understand the system. And so that's what we bring to Georgia, and a solution, and potentially a potential solution to the problem of high-cost care and actually kids entering foster care in general. And what we also do is we avoid the trauma of a child being removed. The doctor from Children's Healthcare of Atlanta talked about if you can prevent that child from going into foster care the first time, you're going to see that benefit 6 times over. That's our goal, is to keep that child from getting into the system the first time by strengthening the family through community around him. So nationally, we're a national program. We're also now in 7 foreign countries. We work with birth to 21. So we will work with young people aging out of foster care. We'll work with young mothers with no parental figure in their life at all the way up to the age 21. We have supported 50,000 kids nationwide. We have 25,000 volunteers nationwide. Safe Families, Representative Cooper asked a lot about workforce. Our workforce is volunteer workforce. We get people from churches, and we get people in Georgia from Volunteer Match that want to actually volunteer. Our volunteers are background screened like foster parents. They get training like foster parents. They have oversight like foster parents. We have all of the same insurances as a children's residential program would have. We are even Council on Accreditation certified. So we have actually put a lot of emphasis on making sure that there's professionalism in Safe Families. What we also do is we offer this at a community base, and it's a low-cost model. Because our primary workforce is volunteers, we use clinicians, master's level, to provide the oversight, to provide training, and then we use voluntary recruitment, and then we have a program called Pastor to Pastor. Because we are a faith-based initiative where we have pastors connect with pastors to actually help us recruit volunteers and help us recruit churches. And the churches provide us with material resources. So if a family needs bedding, if a family needs food, we have a network of churches that provides that to these families so that we can make sure that they have a stable place to be and that their needs are being met. What our goal is to break the circle of social isolation. When families come into DFACS custody or when they have a behavioral health problem themselves, many of their families and their friends fall away. Many times because they've actually burned a lot of bridges, or they have their own behavioral health issues that they need to help manage. What Safe Families volunteers do is they become the person that walks alongside them. To say, let me help you figure out a way to get to treatment. If you have to take one child to the doctor or to therapy, who's going to watch your other children at home? Who's going to pick them up from school? We're that person that when they walk out of the therapist's office, when they leave the doctor's office and they have this list of things they need to do, we're the organization that to help. Can we help you do that list? So when nobody else is around and all the professionals have said, this is a recommendation for you, our volunteers are the ones that say, how can we help you get this done? And how can we help you in a way that's full of dignity and full of respect so that we realize that you love your children and you want them with you? How can we help you stay involved in their life and keep them at home is what our goal is. And we do that through building these relationships that basically help with reduce child maltreatment, help reduce substance abuse on both the part of the parent and the children, help them with things like mood disorders, help them manage their own care as well as their child's care. And what we also do is we also help them, because parents with kids involved with public systems often have low unemployment, high unemployment, and they also have low academic performance. By getting support from Safe Families, we help raise both of those so that they can get an education, they can get a job, so that eventually a child in foster care or in residence has to come home. They have to go somewhere. Our goal is to prepare the parent so when they have to stay involved and have a place for the child to go when they're ready to be discharged. What we do is we do a lot of discharge planning and reunification. If a child is in foster care or is in residential treatment, we can help the family get the work done on their reunification plan. We can help prepare them for the family coming home, for the child coming home, and also if there's siblings in the home. We can help work with those siblings with respite care, with daycare, with transportation to different events, so that the parent can focus on both and they don't have to choose one or the other. What we also do is we help families navigate how they actually do their reunification plans, because many of them are very complicated. Many of the providers are not in the neighborhoods where they live. They have to rely on public transportation. They don't have child care. They may not understand what they're being told. So we actually help them with all of those things because we're with them on a daily basis. They can call us and we can go over, and our volunteers can say, okay, this is what we need to do. How can I help? And we hope, our hope is to help them start a new era of stability so that they don't ever feel isolated again and hopeless. So that's our goal. When there is a sobriety and recovery issue, we can walk alongside them in their recovery. Help them understand that treatment is useful, even though it might be painful. We can encourage them by providing short-term respite for their children so that they can get the treatment they need, helping provide transportation to the treatment they need, and having a relationship that they can build trust with and they can count on so they can develop some resiliency because they know we're not going to walk away. For employment and we do employment and transportation support. We do coaching and mentoring for job readiness. We assist them in helping with applications and and workplace success. We help with transportation to support them to go to their meetings or to get training or to go to counseling, whatever they need. Our volunteers provide all of this support so that we can make sure that the family is ready and can actually meet the goals of the reunification plan or keep the children out of foster care in the first place. If they're involved with counseling, we actually help them and their children get to their therapy appointments. We model parenting skills. Many of our parents, they've never taken their kid to the doctor before. They don't know that they can actually ask questions. They don't know how to interact with therapists. They don't know how to interact with schools. So we're there to model all of that for them by going with them. Our volunteers also are in the community where they live. We do our best to recruit volunteers that are in the same neighborhoods where our parents live, so they understand the culture, they understand the dynamics, they understand the transportation systems, they understand the churches that are in the community, because that is a big plus, because many times these families walk into places and nobody looks like them. We want our volunteers and our staff to look and like their parents and understand the environment that they come from. And all this goes to building a culture of relevance and trust. We work with churches. Currently in Atlanta, we have 3 churches that we're actively recruiting volunteers with. Our program is on the west side of Atlanta. So all of our churches right now are African American churches. We have 6 that we work with, and we're exploring 16 more. We provide childcare, food, job placement assistance, and health services assistance to help them get and maximize their Medicaid. That's why CareSource actually provided us seed funding, because they knew that the parents, we looked at the neighborhoods where there was the highest utilization of Medicaid and a very high removal rate for foster care. And so we chose neighborhoods on the west side of Atlanta. And the goal was, can we help parents make better utilization of their Medicaid benefits so that they can receive the services they need to prevent their children coming into foster care? That's our goal working with CareSource. And then we provide respite care. Our respite care can be anywhere from 1 night to a month. We've done as long as 6 months. But the parent is always involved. The parent always sees their children. And we have a 98% return home from respite care. We, all of our volunteers and our staff, we are all mandatory reporters. We develop a relationship with child welfare. And we do report child abuse and neglect when we see it. And we tell our parents about that. We help work through it with that. But our goal is to keep the child safe in a safe family. But we know that the family is the key. So far, since in 2025, we've served 17 families on the west side of Atlanta. We've impacted 38 kids. We've received 21 referrals. Our latest referrals have been from DFACS. We have currently 17 volunteers that are working with us and 5 in training. And we have 3 active churches, and we're exploring 16. And so this is just a small glimpse of what we've been able to do since the first of the year. Like I said, other states that have where we receive funding from DFACs or from healthcare. In other states, we are funded by TANF, Runaway and Homeless Youth Money. In Florida, we're actually funded by a reimbursement fund from insurance companies. And in other states, we're paid for by straight general fund. And then in Georgia, we're paid for with some Medicaid dollars. And so there's a variety of ways that we've been funded in other states. And we can have this same impact. This is only since the first of the year with grants from CareSource and Kellogg Foundation. So just a typical profile or a story is a mom facing unemployment, homelessness, was referred to Safe Families. What we did is we helped her with transportation and mentorship, and we provided temporary care for her children. We helped her attend job interviews, and she secured employment, and she was able to get a home, and her children were returned. This is a case that could have been a dependency case, kids abandoned, and kids in DFACs. What we do is we get ahead of that and begin to work with parents to say, how can we help with these issues that are critical to keep your families together? So this is how Safe Families works. The family is always the center of what we do. We then provide host families, which are respite care. Our family mentors are family friends. We have family coaches, which actually serve the family friends and host families and support them so they don't get burned out and they have the resources that they need. Plus, that family friend, that family coach, we have what's called a family coach supervisor. That's a master's level therapist that helps oversee safety and all of the concerns that may come up behaviorally, both with the parent and with the children, and make sure they get appropriate resources. Resource friends are people that may never see the family, but they provide food, clothing, shelter. They may fix a car. They may do home repairs. All of this is done through volunteers. And then it's surrounded by, we have a leadership council. So every chapter we have local people that help us recruit volunteers. We have Safe Family staff. I'm a national staff. We have recruitment staff. We have training staff. We have a whole curriculum. So we're an evidence-based practice, so we have fidelity measures. We have a CMS system that tracks all of our families. We work with community partners. And then we do fundraising to help fill in when we don't have state contracts. Any questions on this? So what Safe Families could use in Georgia is one of the things that we face in Georgia, we face in many other states, is we want to make sure that our volunteers have appropriate background checks. Like Georgia and many states, we can do all the background checks we need, except we don't have access to the Child Abuse and Neglect Registry to make sure that and it's like that in most states, unless you have a contract with the state, or if you're a state employee, you don't get access to that. So one of the things that would be really helpful for us is a simple, you can be $0 contract. This is what we want is we want to give you to be able to have access to Abuse and Neglect Registry, because we want to make sure that our volunteers are safe. Because we don't want to put them in any bad situations. What is also helpful is now that we're 4E eligible and we're Family First eligible, when Georgia begins to do its 4E plan, we would like to actually have an opportunity to sit and say, could we be part of this 4E plan and maybe take Safe Families statewide in Georgia with dollars available through 4E as one of the funding sources. Any questions?
Thank you. I see one to start
Okay.
with. Believe it's Representative Cameron.
Yeah, thank you, Madam Chairman. Thank you for your testimony. I think this is rather brilliant. I'd love to see this. I'm up in the northwest corner of Georgia, but I'd love to see this all over Georgia.
Yeah.
Because this is kind of the way in decades gone by we did kind of things where churches were and working together. So thank you for what you're doing.
Yeah, it's one of the things about Safe Families is it's so simple that it's easily replicated. Yeah.
Any other questions or comments from anyone? Chairman Cooper.
Okay, just to make clear, when you say you want access to child abuse or
The
data, okay, you're not asking for data, you're asking to get a clearance.
Yeah.
When they just say yes or no.
Yes, exactly. That's all we want.
It's like we did for the nursing assistants.
Yeah, exactly.
Out at home, they just, it's done through the state, people that check it, and you don't get information about the person, you just get, yes, they're eligible to work at home, or no, they're not. Because they don't share that information with anybody.
That's exactly what we need. Thank you for that clarification.
Any others? We're not seeing any. I want to tell you that we may have more when we begin to dig into this and know how to find you and get in touch with you. But it is, I'm so impressed with your long serving record of work here in Georgia, to have worked with Governor Perdue and to keep stepping forward and in the evolution, I would say, of these challenges that are ever changing all the time. So I appreciate the work you're doing. I think this is exciting about the work in Atlanta particularly, and that's a great place for us to continue to build out. I, like you, think we could, Russell Cameron, think we could also extend this everywhere, particularly some of our more rural areas where the needs are sparse. I mean, the resources are sparse and the needs are huge.
Yeah, and we do have a rural model. We do it in Alaska, we do it in Idaho, we're statewide in Oregon, and statewide in Kansas. And so we do have a track record of doing very rural areas. Yeah.
Wonderful, thank you. Is your funding that, I think you said it was Kellogg and
CareSource.
CareSource,
Uh-huh.
pretty stable?
No, it actually ends in January.
It ends in January?
Yeah.
Okay.
Yeah.
Well, that's good to know. That's
Yeah.
something we need to,
Yeah.
take a look at.
Thank you.
Okay, thank you so much. Appreciate it. Is there anything else?
Also, we have applied in 4 counties in Georgia for opioid funding.
Oh,
Because
good.
we actually get a lot of referrals from substance abuse treatment centers, where we actually work with the children while the parents go through recovery. Yeah.
That would be a great parallel program
Yeah.
to work with those children, I think,
Yeah.
too, and help the families reunite, too, in many circumstances, I think. So.
Thank you.
Okay, I tell you what, we are going to, let me check with Amber 1 minute. Okay, last meeting, Commissioner Broche was not here, couldn't be here. We had great information from it, but she is here today. And if we can just take a few minutes to let you come, either place that you want to, and help us understand a few more things. Whenever you're ready.
Can everyone hear me okay?
Yeah.
All right. All right, well, good morning. I'm glad to be here today. I really just wanted to make myself available to the committee, and I've heard several of your questions and thought I'd try to answer some of them in no particular order, and also just be willing to take any new ones that you have. I thought perhaps it'd be helpful to do a very, very oversimplified explanation of how a child comes into care, and when, from the DFACS perspective, what we mean when we talk about an abandoned child. So at any point, if you have questions, just stop me, because I can ramble. So for a child to come into DFACS custody or to be on our radar, we need to have a report. So you're going to have people that call us, they're going to call the CPS hotline, and they'll have allegations of abuse or neglect. And they'll identify the child's caretakers, or if it's not their caretakers, some maltreater of the child. And so that, at a centralized office, they'll evaluate the report. There'll be consultation with the county DFACS office. and there will be a decision made on what we do with it. So sometimes we will get that information, and it won't be enough to demonstrate that there's child abuse or neglect, and so, or it may be that we already have an open investigation, and so it'll be technically a screen out, which can be alarming for some people, right? They'll see screen out, but in fact, it will be that we already are working on it. But that can be a screen out, or it can be that we think it does prompt additional investigation, and so we will do a safety assessment. We'll have that county start working on it. We'll assign it to a case manager, and they'll try to go make contact with the child and the caretakers. What we're looking for legally is we're looking for, again, this is very oversimplified, but for purposes of the hearing, ultimately what we're looking for is whether there's evidence that the child is dependent. And in the juvenile code, there's a bunch of different categories for what constitutes dependency. And broadly, it's abuse or neglect. Abandonment is a subcategory of neglect. And the way that it's defined is pretty specific. So it's got like a long running list of the different things that can constitute abandonment, but then there's sort of a catch-all subcategory. But ultimately, you'd have to, for us, we need to be able to identify enough evidence that shows that the child has been abandoned, actually, not just that there's a threat of abandonment, in order for us to determine the child is dependent and then try to take additional action to protect that child. So when we get reports of abandonment, typically we're going to get those kinds of reports from healthcare facilities. So we'll get them from hospitals and emergency rooms where, the child's been there. It's typically going to be like a teenager, and they were in some kind of healthcare crisis, and now things have calmed down, and their parent or their caretaker is not there, and they are not going to come back, is what they're saying. Or the hospital can't reach them, or some other healthcare facility cannot reach them, and they don't know what to do. And so that kicks off the process I just described. Sometimes it will be that we get those calls from a detention facility. So you'll have a child that has some type of delinquency issue, and they've been in detention, and it's time for their release. And again, it's their caretaker is not willing, or they're unable, or they can't be reached to come get that child, and so we get the call and it kicks off that process. But what's important about that is that we have a process, and what can be frustrating for so many people is that they, and understandably so, they don't want to wait around for the process, but we have to. I mean, legally, there's so many reasons for why we need to do that. I mean, we need to protect the child's rights. We need to protect their parents' rights. I mean, we're the state. We have to consider the serious constitutional considerations in our involvement in that family's life and that child's life. And so we need to have a very thorough investigation before we would rip a child away or do anything that would be an intervention, right? But it's definitely going to cause issues for our community partners whenever they don't know what to do in this scenario, and it's rough on the child. I mean, it's really traumatic if you are sitting there and you don't really know who's going to respond. So all of that to be said, in terms of statistics, I can probably get some pretty good statistics for you. There's one thing that DFACS, well, there's several things we're good at. We don't often get credit for them. But we are really good at data. So I can probably get you some really good statistics on abandonment in the dependency context. Now, children with these abandonment type issues can have juvenile court involvement where we're not in the picture, at least yet. Those can be child in need of services cases or CHINS cases, and then I mentioned like delinquency type cases. So I won't readily have those data points, but I can tell you what ours would be, and I'll get those to you, Chairwoman Dempsey. But typically, the children that, if we do determine they're dependent by virtue of dependency, again, oversimplifying, but those are generally going to be teenagers, and they're going to have incredibly complex mental health needs and behavioral health needs. And by the time they reach us, I mean, it's going to be incredibly hard for us to find immediately for us to find a placement, right? So we're going to try to scan high and low for preferably a foster home. That's always, we want to find a relative, right? We want to find a relative, we want to find fictive kin, someone that they know and they trust, and we want to make sure that those people are vetted. If that doesn't work out, we're going to look for a foster home. And if we cannot find one that's able to meet the child's needs, then we're going to start looking at group homes. And we have different levels of these foster homes and group homes, and we pay them according to the level of care that they're willing to provide to the child based on their needs. We can negotiate that payment level as needed. We've put more flexibility into that structure because more and more the children that come into our custody are incredibly complex. We don't know what to attribute the change to, but it has been an exponential increase in complexity is what my veteran staff tell me over and over, and you can see it in the costs that we're incurring in recent years. But we're looking for a placement, and or we're immediately looking for a healthcare facility. We're looking for treatment. We're looking for residential treatment, and if we're looking for a psychiatric residential treatment facility, we are looking in-state, and I think it's, six PRTFs within the state. And that means we're competing with every out-of-state private payer, Medicaid payer, other payer, I guess, TRICARE, any other payer nationally for the in-state beds. And then those facilities are going to have what could be restrictive criteria. So, for example, if this child is of a certain low IQ, right, they may not be eligible for those beds. Or if they have autism, like that may immediately take them off the table for consideration. And so it can become incredibly difficult. It becomes a bidding war. So really, if we have any, and I'm just going to speak plainly, if we have any trouble whatsoever with trying to leverage the Medicaid dollars to get the approval for coverage for that level of care, but we feel confident based on the clinical recommendations that we've gotten, and we don't make these recommendations on our own, we're getting clinical recommendations. If we feel like the child needs it, but we can't get their CMO or straight Medicaid to cover it, then we're going to pay for it with state dollars. And so we're going to be at the table in a bidding war against all of these other entities for those very limited beds in state. We try to limit what we look for out of state, primarily because we don't want to do that to the child, but also because legally we are restricted from doing that. And that's an important safeguard that we closely follow. So we have what I would say are probably, again, this is oversimplifying, but generally you've got sort of two main categories of caretakers when we're talking about abandoned children. You've got caretakers who are totally exhausted. So they are you can tell they've been trying. They have, you can see, because we will often get the records, right? These families will sign releases, they'll work with us, in interviews, they'll tell us, I've tried this, I've tried that, we've gone to therapy, we've called this CSB, they're not hiding the ball. They are telling us the things that they've tried to do, or they're telling us, I am so confused about where I'm supposed to go to get help. So it's obvious to us, or becomes obvious, that they've attempted to navigate various systems to get assistance. Then you have the other category, which are parents that have not bothered to try to get help for their child. And they are like, where do I sign the paperwork to surrender them to the state? I'm ready. Give me the paper. And that is not how it works, but they think that they can do it that way. And so that's the general framework. Sometimes we will have juvenile courts order children into our custody, at hearings where we're not present. That has been dramatically curtailed because of recent legislative changes. So we have a lot more input in those processes now. But hopefully it kind of explains, start to finish, how we're interacting with these children.
We've got a question, if you've got a
Sure.
minute to pause just a second. Representative Oliver.
Thank you very much. I agree with you that the abandonment law in different contexts really doesn't fit
Right.
the emergency hospital. I'm sensitive to that. Somebody sent me that we have increased the PRTF rates in the last 2 years, and I wondered if I asked this question to Dr. Constantino, do you know whether that's changed the percentage of out-of-state children that are coming and taking Georgia beds at this point? Because we've had 2 years of reimbursement rates up above $600 now.
So, yes, it has. But if I'm being completely honest with you, I would say that's more so out of the goodness of our providers' hearts and not so much because of the increase. I hope I don't get in trouble for saying it that way, but I think that's true. And here's why. It's really hard to get the numbers of I know, but it is almost impossible. So whenever I have been able to track down the numbers, it's been that these providers are like, please don't tell anyone you got it from me, but Florida pays $800 a day and California pays $1,000 a day. And so if Georgia's, less than 800, we're going to lose the bidding war. And that means that my agency needs to find a way to pony up with state funds.
If you called up Hillside and said, how many out-of-state children do you have, would they tell you?
I mean, no. Well, I mean, I wouldn't, right? I wouldn't readily disclose that to DFACS. They have important privacy concerns, but technically speaking, there's a different division within my agency, the Interstate Compact for the Placement of Children, where they have the authority to ask them that question, and so they would, I think, legally need to disclose it.
That's just confusing to me. I mean, you could file an open records record. I mean, I do
know.
that all the time.
Now, I will
Yes.
say in that regard, though, some states, even though states are supposed to be telling each state's ICPC office when they're moving kids across state lines for placement in residential facilities, so it should be that I could get this information and that you could get this information. But some states will not report it to the state's ICPC office because they don't want that state to know that their child is placed there.
Perhaps you help us figure out how to follow up. One other there is a federal law that mandates when a child is assigned to both DJJ and DFACS, extra money comes with that, extra resources comes with that. And it used to be that you had somebody tracking that additional 4E money. I wondered if this 40% of children that are involved in both DJJ and DFACS for this 150 really surprised me.
Yes, so we call those dually designated youth.
Right.
The reality is that we often don't know. I mean, more often than not, we don't know if a child has DJJ involvement.
How can you not know?
We don't have access to the system. It's some local, look, I work incredibly closely with the DJJ commissioner, like, we've made a lot of strides in this regard. But there are also local juvenile probation offices. They're not run by DJJ, right? So I don't have access to those records and systems.
What's interesting to me is that this is a federal mandate, and you have to report all this. So I'm curious about, because it used to be a fairly small number. I don't remember the details, but 40% is a very large number. And it seems, I'm curious what's going on there. But maybe somebody can help follow up on that. I won't take more of your time on that.
It is, I mean, delinquency involved youth, that's certainly a big chunk of these kids. And in terms of the 4E funding aspect of it, I mean, you know this because we've talked about it before. Georgia just doesn't get to leverage the 4E funding stream like most or many other states, certainly not like our neighbors, because we're held to an income threshold or income cap.
I don't think that's true for the dually diagnosed, but I could be wrong about that.
Well, you might be right. I've always I just know that we don't leverage 4E funding because we're always
because of the
stuck.
formula issue, but this is a subset. Thank you, Madam Chair. Thank you.
Thank you. We'll bring you back to where you were.
Mm-hmm.
Okay.
In terms of, let's see, data sharing. So, once a child comes into our custody, we're the legal parent. And so that means we're entitled to their records. And we do act that way. I can tell you, if I log into our system and look at any particular child with a certainty, I know that case manager is going to either be in the process of getting their medical records or will have already gotten them, at least for the providers that he or she knows about. But that is a onesie twosie, process. It's going through each and every single one of them. There is not an ability for a case manager to just look into a centralized health record across state agencies. I think that will change, and there have been efforts. We all want to do that. We want to see that. And certainly it's easier for me now to ask all of my sister agencies, can you give me this child's records? Can you give me that? Than it was even just a few years ago. But it still is at the case manager level, very much so, discrete requests. Yes, sorry.
No. So if you had a portal, and I go back to the insurance industry and working with CMS. If you had a portal where you could Candace Bros and put the date of birth, and it goes across all those agencies and just pulls you in, would that not be helpful?
It'd be immensely helpful.
And that's not difficult to do, I don't think.
No.
But the silos, it seems like we have silos in state government where, maybe it's unintentional, but there's silos, and this part doesn't talk to this part, doesn't talk to that part. And
right. Well, the data's all there. I know that. We have really incredible data sources. And there has been progress to get everything to talk to each other more. But every child that comes into our custody, absent some very narrow exceptions, goes on to managed care Medicaid. Unless that changes with the new contracts, it has not been a requirement for the managed care company that has that existing contract to require the providers to have electronic health records. So there's no centralized health care record for even that contract. There's the Georgia Health Information Network, GHIN is what we call it. My system, our case management system, is in fact integrated with that. So if providers were required to upload all records into that, then we could readily pull it down, but they're not. So, those are things that can be remedied. We have done a lot of big technology projects in the past 4 years to make the records within our possession more easily available to the people that are involved in that child's life. The biggest one, I think, is Communicare. So a big complaint that we have is that my DFACS case manager doesn't respond, I'm sure all of you have heard that. So that particular technology portal is set up so that I think it's birth parents, CASAs, foster parents, I think those are the main categories, can log into that system and access the records that they are legally entitled to get on demand, right? So that can include health records. And that goes a long way, right? So that at least they can be informed, but it doesn't go to the ultimate issue, which is there needs to be more integration statewide. Okay. Let's see. I know that ultimately you'll be looking for things that are recommendations for change. And, I don't have like a list for you. But I do know that if I were to poll case managers, they would say that they wish that there were more beds, especially for residential care. But they even at that level, they say it's just a hard topic. It's a difficult conversation to have because so many people are afraid that when you say you want to put a child in residential psychiatric care, that you're talking about like inappropriate institutionalization. And so it's just a really tough conversation to have. But the children that we work with, where they are saying that that's what the child needs, I mean, they're talking about children that really there's no alternative. And certainly a short-term 5-7 day stay is not going to cut it. We resort to using state dollars to pay for the care that they need if it gets denied, because in my assessment, it's probably going to be cheaper than whatever the emergency room stay would be. And it's going to be cheaper or equivalent, maybe a little bit more expensive, depends on the child, of what a hotel stay would be, but ultimately they're getting care. So I think that's what the state should pay for, which means I come back every year and I ask you for more money. But I think that's what we should do for the children that we serve. I do see that, not a knock on providers in this space, but it is bothersome that there's not more robust discharge planning. I have personally filed some complaints against just a very small number of providers in this space because they are, in my opinion, in my interpretation, required to engage in comprehensive discharge planning. They need to be engaging with the family, helping these parents or their caretakers be ready for this child to come home. They need to explain some options and, the clinical care the child received and follow up and, help them get ready. The same way that DFACS would help them get ready, you're empowered to help them get ready to the best of your ability. Sometimes we don't see that. And so the abandonment, that issue can arise because they're terrified. They don't know what they're supposed to be doing. And I think that could actually move the needle if there was more accountability for discharge planning and making sure that there's a safe plan in place. I'm probably going to get a bunch of text messages from staff that are like, why didn't you mention this whenever you're up there and you have the microphone? So let me make sure I don't have anything in particular. I know, right? Okay, I think I'm good, but hopefully I sufficiently covered the DFAC side of the abandonment issue.
Are there any questions from the committee? And your team did a great job last time too.
Good,
So
good.
Chairman Cooper.
Okay. I'm going to ask about our case managers.
Mm-hmm.
Do you have sufficient case managers? mean, are you to handle the cases that we have in the areas?
I mean, you can always have lower caseloads. We've been incredibly fortunate to have, significant workforce investment. So thank you. And our turnover is down. I would take more case managers if you want to fund more case managers, and the governor wants to fund more case managers. But what my current workforce would tell you is that this is a small group of children in our custody, but they take up, I hate to put it this way because we're glad to serve them, but it's a tremendous amount of bandwidth, right? Because of their needs. And that means for a child that is abandoned when there were so many other ways to prevent that, like so many other options along the way to get them care or to keep them in their home with other interventions instead of them becoming an orphan or a child in care. That is really hard on them because it means for the rest of their caseload, it means they can be taken away and they don't feel like they're able to do the job that they would want equally amongst the children that they are assigned to care for. They also would tell you that there's a expectation that DFACS workers are caregivers, and they're not. They didn't go to school to be a caregiver. That's why we contract with providers to do that, or we recruit foster homes. But they certainly are expected to do that kind of care, and they don't know how to do that. They don't know how to provide like clinical level care, and so that can be really tough. There's a lot of burnout.
What are their qualifications to be a caseworker?
So many of them have master's degrees. So these are incredibly well-educated people that are doing really, really, really tough jobs. But it's usually social work, so it's going to be in the human services type fields. But it could be really any type of bachelor's degree. But again, so many of them have master's degrees.
Okay. When I came to the legislature long ago, we weren't even given our caseworkers phones when they would go out in these horrible situations where families were fighting or, against what they were doing. Mm-hmm. We are taking better care of them, aren't we, when we send them out into, they do have ways of communication and backup.
Oh, yes. Although you would still be surprised that so many of them are just fearless. They just walk right in. Huh? Well, yeah. They just want to work with the family. It doesn't faze them. Just want to save the children,
Right.
Yeah.
It is a means of dedication.
Absolutely.
Because they do go, anytime a family is breaking up or a child has the threat of being taken, it's a really explosive situation for everybody involved.
Yeah, it can be very, very dangerous.
So the job they have is very important. Does each county, in public health, each county has a public health department. Mm-hmm. And they have a board that, is that the same way with DFACS?
We have local boards. Mm-hmm.
Does the county commission make the rules for what happens in DFACS?
No.
No, it's still, they follow.
No. So in some other states, so the general framework for how each state's child welfare agency operates can be different. It can be like county run, it can be state run. We're a state run agency. We do have county boards that are very involved in that county's DFACS work and even specific cases, but ultimately we're a state level administered agency.
But unlike public health, where sometimes they just ignore
Right.
directives from the state.
Yeah, oh, no,
anything
no.
like that.
It's
We don't have that problem.
The state sets the policies, we issue the directives.
And I'm one last question, I guess. I don't usually want to think we should tell businesses what to do, but are there any states that say to people who are doing these long-term beds that they have to take state patients first, or they have to take a certain amount of them, or anything like that that you know of?
I know there have been conversations about that. I think there may be, I think there might have been, I don't want to get it wrong. So I think I've heard a neighboring state might have toyed with the notion of like for state funded beds that they could do that.
State-funded beds.
But not for federally funded beds, like Medicaid funded or TRICARE funded beds.
Right.
They wouldn't give that kind of preferential treatment for risk of some kind of CMS or related finding. I'll have to dig more into that to see. Now, states also, through the interstate compact for the placement of children offices that every one of them has,
Right.
States can set the criteria for what they require of another state that wants to send a child into the state to place in a facility. So there's some wiggle room there, that if the sending state doesn't fill out all the right paperwork and give all the right information, that we could reject the child coming into the state of Georgia for placement in one of those beds. But that's generally going to be something administrative. It can't be because the child's from another state.
I mean,
Yeah.
you hate to think about, and not private businesses, but if we're paying for it on the state level for our Medicaid children,
So in that vein, then you remind me. So there's also this just canyon, right? There's no intermediate level of care. So that's something too. Our agency has started to. We have a couple of pilots for qualified residential treatment programs, which is what we think is going to eventually be a good step down option for more intensive type residential treatment in psychiatric care or partial hospitalization. But any opportunity to expand the types of facilities that would fit in that step down level of care would be fantastic. And that may literally be creating new facility types, since it doesn't really seem to exist.
Okay, thank you very much.
Great, good. Any other questions or comments? Well, let me ask you one thing, and I did want to say, I know when we talked about connectivity at one point, those caseworkers, some of that has been addressed with broadband issues that have expanded into our rural areas. There was a moment in time when they were in places with phones that they didn't have service and often had to drive to a more public spot to actually upload the records.
All of them have hotspots on their work phones.
Good. That's making a huge difference, I think. Do you, just while we've got you for just a minute, do you have any updates on the Family First Prevention Act status?
Yeah, so so the Families First federal law that passed 2017, is that right? I think it was 2017, and that expanded states' ability to use the Title IV funding stream on preventative services to keep children out of foster care, whereas it was being used really for funding foster care. So Georgia prepared, the majority of this work was done before I moved over to DFACS in July 2021. But we developed a plan for the preventative services that we would develop and the pilot sites that we would select for rolling those out. And that was in Cherokee County, I think Richmond, Chatham, and I'm going to miss the fourth offhand just because I'm on the spot. But it was like family therapies, multi-systemic therapies, these things that with vetted providers in those specific areas would be these preventative services that we would provide to families to hopefully prevent foster care. And so we had to go through a bid process and all that. So that's been implemented. I think we're still, even though it's been some time, we're still waiting to get really robust results from what that looks like. And in some places, it hasn't been that there have been really enough referrals for those types of services to see the data that we thought that we would. But particularly talking about qualified residential treatment programs, that was a big component of the Families First Act. And it was really a big change in how states funded congregate care group homes. So that change in the law restricted states' ability to use 4E as the funding stream to pay for a child's stay in a group home for more than 2 weeks, unless it was a qualified residential treatment program, or it met some other exception. And that has been quite tough on states, Georgia in particular. It's been very, very tough on us, but now that we have started to roll out these qualified residential treatment programs, we're really seeing some good results. We did one with the first pilot site was with Murphy Harps. It was technically 12 beds in Cedartown for boys, and that's been at capacity from basically the day we had that established. And we're looking at a second one for girls, and I can't remember offhand. I also don't want to get the provider wrong if we're still nailing down the details, but I think we're about to announce the second one for girls.
Good. Well, thank you. Well, thanks for sticking around and helping us update a couple of those things. Appreciate it.
Thank you.
Yeah. So we are going to pause and take a short lunch break, about 45 minutes. We do have lunch across the hall for the committee, for the presenters, and for anyone that is here helping you in that work, too. If y'all would join us over there. And so it's 12:18. Let's say we'll start at 1 o'clock again. Thank you. Okay. Okay, we'll go ahead and get started again. I will tell you, I know, I love seeing everybody talking. We're all so excited, actually, about what's already coming out of this committee. While we had lunch, there was just a lot of great conversation going on, too. I just think we've got a problem that we're going to try to make no longer a problem here pretty soon, I think. So let's get back on track here. We've got a real treat. Our next speaker is Georgia's Parent Support Network, Dr. Sue Smith. Sue, when you come up here, where would you rather be? Would you rather sit or stand?
Oh, I would rather stand.
Okay. We'll turn that on there, but I want you to tell everybody just a little bit about you too, because they may not know you as well as I do.
Okay.
Do we have a handout for that?
Well, first of all,
I don't think
you
so.
need to know I have a wicked sense of humor. So I'm going to start by saying, now you see a signature with his, theirs, mine after it. Old is after mine. So I'm Sue Smith with the Georgia Parent Support Network, and can you hear me? Okay. You need to know I'm hearing impaired, and my Bluetooth is not picking up in here, so just assume I'm deaf. I'm Sue Smith with the Georgia Parent Support Network. It's an organization founded 36 years ago by a group of 30 people in Macon, Georgia, including a couple of legislators. And in the last 36 years, we've done a great number of things, as most of you probably are aware of. I was the CEO for 36 years. I retired January the 1st. I am now, I can't remember my new title, Chief of Peer Services and Operations. And our new CEO, ta-da, there she is. We are so fortunate. We are so incredibly fortunate. Anna has been right here since she was, like we are, way younger. So I've listened to some incredible stuff today, and I don't really know what to say. I'm going to say a few things in different areas. So first I'm going to tell you why I'm here. I'm here because I was the parent who gave up custody to get services. And I've heard conversations all over the place today. Danny, some of you even might remember her name, was 4 or 5? She'll be 49 next year. So it was a long time ago. And the experience might be vastly different, right? Given today's services, it's not. It's just exactly like it was then. We were middle class. We had money. I worked for Eastern Airlines, best insurance in the world at the time, everything paid for. First, I want to say Danny was adopted. We found her in a Waffle House. Her mother was a waitress. They lived in a car, and Danny was 3. We adopted Danny, and in the meantime, we kind of got her mother, Debbie, too, who will forever remain one of my best friends. She has now passed. So, in my 20 minutes, I couldn't begin to tell you about Danny's life. But she came to us from a family with a history of profound mental illness. Her aunt and uncle committed suicide at some point in this story. But I had teenage children. And we took her home with us, and we loved her. My grandmother said that was enough. That did not tend to be true. We did everything. We maxed out. She had the best doctors at Emory. She had the best care. I was not an educated person at that point. Danny gave me an education. There were no typewriters and no cell phones. I wrote 200 letters to the people that I thought were most important in this state. And guess what, guys? You wrote back. And you got involved. Go further down the road. Our insurance has run out. My husband's working for Emory. They had good insurance, too. His insurance has run out. We put her in a private school near Emory. I think, maybe 4th grade? She threw the desk at the teacher. Now, this is after Emory psychiatrist, the best medication, not appropriate today, but it's what they used then, the best services. Fast forward a little more. We're now broke because after the insurance ran out, we paid for the services. I'd walk into somebody new's office and they'd say, "What'd you do to cause this?" And I'm going, "Thank God for Debbie. She gets to take the rap for this, not me." So it's been a long life in your field. I thank you for listening and trying and working on this solution. I'm with you. I've been with you a lot of years. Danny's experience led to the founding of Georgia Parent Support Network. The state of Georgia was looking for 5 parents, couldn't find 5. They found me easily because I wouldn't shut up, right? And so I got to go to Washington. I went 3 years in a row. Families as Allies is starting through SAMHSA, the then whatever it was, now SAMHSA. And I'd come home. It's not what I thought I'd be doing with my life. At that point, I was a custom jeweler, making really nice jewelry for really rich people. And one day, he just kept bugging me, my husband, Norman. He would go, we're driving down the road to Macon, and he says, "Well, what are you going to do with it? I don't want to hear any more about anything about it if you're not going to do something about it." So that resulted in the 30 people in Macon. And since I don't have much time, and there's a whole bunch of stuff to say, I want to say that all of this grew because of people like you, legislators of the time, people of the time, employees of the state. You know, we heard programs that are excellent. We, as Georgia Parent Support Network, have been blessed through the years to have the opportunity, through a lot of funding from a lot of good people, including you guys, to build some amazing programs. Amazing programs. They work. We know they work. They worked. How do we do this and then lose what we've learned and we're here again? We need to build forward, and I understand your challenges. I live them. I want to go back just a little bit. In the process of getting Danny's services, after the money ran out, I stood in front of a mirror one day and thought, I'll just end my life and hers. And then I thought again, and I thought, no, I want to live. And so Sherry Finn, Mental Health Association of Georgia at the time, said, well, you can give up custody and she'll still get the services she needs. And that began where you are starting, probably. I don't have time. Maybe one day I'll write a book. I'm sorry?
Tell us your story. Yes, okay, do that now.
Yeah. So this piece of the story is I have some pretty severe post-traumatic stress disorder from this part of the story. We went to a court. The court said that my husband and I would have to pay child support equal to 1/3 of everything that we paid every month, although we had just gone bankrupt, trying to pay the medical bills that we couldn't pay after we lost everything. And we struggled and did that. And one morning, we couldn't pay together. We had to pay separately. One morning, before dawn, knock on my door, and there's a warrant for my arrest for non-payment of child support. I was taken to the courthouse to wait for a judge that wasn't a judge. It was a box on a stand where we explained that it was a mix-up, and eventually about 6 hours later, somebody from Department of Family and Children came and said it was all right for me to go free, but there'd be a $76 court charge, which I couldn't pay, didn't have the money, and the judge said he was going to lock me up. At that point, my husband absolutely, totally lost it, right there in the courtroom. And so these are just the high points. This is not the everyday trying to live with this child that we love very much and couldn't get her services. So I'm not going to go on with the Danny story except to skip forward. One of the things that helped to no longer exist, Therapeutic Outdoor Center, okay, it was absolutely wonderful, LaGrange, Georgia. She spent 3 years at Hillside. Can't even get those services anymore. Try getting 3 years at Hillside. And she wasn't, if you think high-end user, think that a psychiatrist at Emory told us to go home and lock our doors, she was going to kill us. She was 6 years old. Okay? So when I hear us talk about the possible solutions, and over these 36 years at Georgia Parent Support Network, we've tried some of them. We've built some of them. We've lived some of them with parents. When we do these conversations, as we have done this morning, it's easy to say we've got the parents and youth in mind. But there is no way to understand what people are going through. And we were not a poor family. And we were not a poor person that didn't know how to access services. We knew, my husband worked at Emory. He worked with the doctors. I worked at Eastern. We had great insurance. How did it happen to us? I have a dear friend named Carl Dennis. You may have heard of him. He tells a story similar to this, and it wasn't us. He said first they had everything, and then they had nothing, and they were just like the person that was still struggling to get services. But I don't want to talk anymore about money except to tell you she, through a lot of people and a lot of help and a lot of great services, God bless Grady High School, she graduated. She got a scholarship. She went to Piedmont College. She was doing fairly well, had dropping classes down to a fine art, but she was doing well. I was in Washington, doctor in North Georgia told her, she went to the doctor, she didn't need that medicine, he didn't know why she got it. And 10 days later, she was back in the hospital and lost all her scholarships. She eventually graduated, has done well in life. Medically, she's not well now. And she was the kid who 9 Emmy interns stood around her bed and said, don't take her back. Don't get her out of this hospital. She's never going to do anything. So that's Danny. Now I want to talk 1 or 2 minutes about Georgia Parent Support Network. We've been blessed to be funded through a lot of good people, a lot of cool services that work. We heard Mr. Abel talk about his work. It's kind of like that. The things that we do are kind of like that. They are services that are kind of down home, building on natural resources and natural people. I want to talk about CHAMPS, and I brought you a brochure. These are like 25 years old or so. This program was started by Ernestine Pittman in Fulton County when Fulton County was its own region. She brought together all the experts and all the people nationwide, and she developed a plan, and I'm not going to go into it too much because it's all here, where our community in Fulton County comprised of, in the end, 36-something agencies that actually were facilitated, headed, and billed through Georgia Parent Support Network, developed a network that could serve any kid or family in Fulton County immediately. There was no wait. We didn't have to wait for services. We had immediate access to cash, moving vans, peers. They were not called peers as the ones you've heard about. They were just family people that were trained. Abel kind of talked about them. We just called them parents. And if we got a call for a really severe, and the referrals came from everybody. They came from courts. Anybody remember Sammy Jones? Judge extraordinary. They came from Sammy. They came from Fulton Court. I'm not going to remember his name. And schools, agencies, mental health. And we would bring all of these resources that met every Thursday, and we would staff every kid sent to us. At the table, you had 5 hospitals, you had aftercare, you had therapeutic foster care, you had everybody. These were all the head agencies. You had Chris Kids at the time, now Chris 180, Sally Buchanan. So we were all at this table staffing every kid in Fulton County that was referred by anybody. The charge and the money, and we billed. We billed for services that we didn't have to have cash for. We billed, we served, and we could have, I could do this with stories. So one day I got this call from this mom, and she said, I'm fixing to take my kid over to Georgia Regional. I said, well, just wait. She says, no, I'll call you back. I'm being evicted. They're putting my stuff on the street, and I'm going to get in the car and take him over to the hospital because we can't handle him. I said, sit on your stuff. Go out on the curb, sit on your stuff. We're sending a truck. We'll move your stuff. We'll put it in storage. We'll take care of you. We did it. We got her moved, got her stuff, got her in an apartment, had then time to talk to her, stabilized the situation, plugged in some community services, wrote an IEP, etc., worked with her landlord, got her back in a place, diverted hospitalization. One of the first things we did when we started this program was we had a person, Georgia Regional Atlanta and, help me, Briarcliff, the old hospital that's now gone. We had a person that if a child came in from Fulton County, we had a person there working on a plan to get them out. How long will it be? A coordinator, let us help the family, stabilize the situation. I bring this up today because these are what it's going to take. We've heard in glowing color terms for more beds. Yes, you need more beds. More services, more access, faster access. But the ability of a program like CHAMPS, and CHAMPS is long gone. It went the way of, anybody remember when the kids' services crashed in Georgia? I'm sure some of you do. But anyway, we had a lot of services and then there were not many overnight. So those are the kinds of things that when I've read some of your work, I've read some of your reports, I've listened to some of your videos, looked at the original legislation, and my hope would be that everything you're working for works, that everything that you're working for takes us steps further. And to the understanding, number one, that I've never met a parent yet who didn't want their kid, ever. I've met some parents that couldn't deal with their kids the way they are. In the midst of this, I was a school teacher in DeKalb County in the midst of my story. And we woke up one morning back when news was different, and this woman had killed her kid and herself. And then it told a little bit about how she had looked for services. And it was an eye-awakening thing. However, the same thing could happen today. You have worked for years, most of you for years, working on this challenge. What to do with us, what to do with our kids, what to do with the Dannies of this world. I am so proud of you, so incredibly proud of you, because how hard must it be every single day for you to listen to this? And it is through your work that we've come as far as we've come. As defeating as it might sound, sitting here every day, you have and we have a way more options than we did 36 years ago when we started. A way more. Science has taken us, medication's better, we know more about how to treat our kids, right? The more state-of-the-art, we don't have to redo Milledgeville, we can do some really way better stuff. So I hope, and I wondered listening to your speakers before me, what we had to give, what I had to give to you that might be helpful. So I would wish to leave you with the changes Danny's made with her life in this world. Every single member of my family was changed profoundly, and every single one of them has worked to make a better life in Georgia for children because of Danny. And then sometimes my eagle twin over here goes, what would have happened if there'd been no Danny? So, whole different life for all of us. Thank you so much for having me. Thank you for all these years, continued support of Georgia Parent Support Network. I do want to say one last word. Peers, peers, and more peers. I know you hear them. I should have been talking about them, but I'm not. But they are the future. They're the families that helped us all those years ago with some formalized credibility. So I think peers are one of the part of the future. And I have no idea how many minutes I took, but I'm sure that's most of them. So I brought you original from 1930, 30 years ago, the Champs brochure, because this worked. We were charged with serving the 200 most severe cases. Thank you. I could have taken it down. The 200 most severe cases in Georgia, most severe referrals in Atlanta. And with the money that you gave us collectively, for those 200 children, we served 600 a year, because we could get the moving van to the street. We could spend a couple of $100s for hotel room, food, etc. We could have a few peers plug in some services or access existing services much cheaper than you could pay for 2 or 3 weeks at Georgia Regional Atlanta. So that's not against hospitals, it's just a fact. Thank you so much. Any questions?
Let me ask something. You said you were given money to approximately help 200, and you wound up serving how many?
600, a little over 600. Now, it took a minute to get there. We started with, the mandate for the money came through the regional board, Fulton County Regional Board. One region, Fulton County was its own region. And it started with that money, which was our money to build the kids. Remember when every county got the money? Fulton was last because it was the most complicated, and we were the answer to the problem. That's a true fact. So agencies were mandated to attend the Thursday meetings and staff the kids, or they didn't keep getting paid. They really just did not get their part of this. And so it took a year to get the school systems to the table. They were the slowest in getting there. People like Grady, Grady was there first. God bless Marie Simmons, if anybody might remember her. Grady kids, of course Grady doesn't have kids anymore, but this was back in the day. Chris Kids, Kathy was there. These were people that were there in the beginning. Jean Toole was with us, although she was adult. She helped us with some transition. You would remember and know the names if you've been doing this a long time, but yes. So, anybody else?
Frank, I was going to ask you a question that I think you already answered. So, would it be fair to say that the biggest need and concern would be to have peers? That everybody needs a peer?
Everybody
A friend.
needs a peer. Here's one of the things that happened with us. When people decided to try to say how good we were, how well we did, we were supposed to have surveys for our families. And so we sent all of our families that we had served surveys. And we said case manager, therapist, hospital, whatever, about 10 things, services. And people didn't answer. And people left part of it blank. So we went back and we said, we looked up the parent that was their contact. How did you like what Natalie did for you? How did you like what, your therapist, your doctor, whomever they had been served by? Absolutely, head and shoulders above everybody else was the first parent contact they had. So, did they need the services? Yes. Could they accept them or understand them without the parent liaison? No. And it's true of me. It was true for me, too.
Wonderful. Are there any questions or comments from the committee?
Thank you.
Yeah.
Thank you, guys.
Representative Cooper.
Thanks.
I just want to thank you for Danny and for what your family was willing to give to try to help a child that wasn't your own. I've got a neighbor that went through the same thing. That child is now out of the country because the services she could get were not enough for her to keep her from threatening to kill the family and other problems. And I watched what they went through, and they, had the ability to get services too, and tried and tried and tried. So I often say that people can have lobbyists come and talk to us, But when somebody like you comes and tells us your story, it's worth 100 lobbyists. So thank you for what you've done, the person you are, and for coming and sharing your story with us. Thank you.
Thank you so much. It makes me feel good. Now I will not become a lobbyist.
No, don't.
Not that there's a thing wrong with them, but I'm just kidding you. But it's, I'll leave you with this. I believe in miracles. I truly believe in miracles. It's not something I just say. I believe in miracles. Not everything that we think is bad, it could be a miracle. It changes something and things change. So just keep in mind that every step of the way, I believe there's a miracle that brought me here, that sent us Danny, that put it all right out there for us. Thank you.
Thank you, Sue. You persevere. That's what we need you to do, without a doubt. You keep doing what you're doing. And our final speaker for today is from the Georgia Advocacy Office, Joe Sarah. Tell us about you, Joe, so everybody knows. And don't feel constrained by time. We're fine. We're good. Thank you.
Thank you, sir. Appreciate y'all. Oh, thank you. Appreciate it, Sue.
Can you all hear me okay? Great. So my name is Joe Sarah. I work at the Georgia Advocacy Office. I have a master's degree in social work, but most importantly, I have lived experience standing beside both family, friends, and children that I serve daily on their journey through life and their seeking of services and staying with family and just living the dream that all kids want to pursue. So for those that may not be familiar with us, the Georgia Advocacy Office is a federally mandated protection and advocacy system. We've been in existence since the 70s. We operate under federal legislation, and our primary responsibility is to investigate abuse, neglect, and suspicious deaths of people that experience disabilities within the state of Georgia. My 20 years since graduating from Georgia State University has been spent standing beside family raising children with disabilities. That has ranged from kids with medical complexities all the way to the other side of the spectrum to include kids with medical disabilities, psychiatric disabilities, as well as developmental disabilities. So some kids that have some pretty complex needs. I spend a lot of time in institutional settings and facilities investigating the reports of abuse, neglect, and deaths that are reported to our office. But my purpose for being here today is through the work that we do at the Georgia Advocacy Office as related to children and youth that experience disabilities through the Children's Freedom Initiative. The Children's Freedom Initiative was established in 2005, and there was actually a House resolution that supported that. I believe it was House Resolution 633. And our whole goal, our mission, our vision, and our value system is all based on making sure that kids are growing up and being supported by loving, permanent homes, with the understanding that that may not always be a biological family's home given the circumstances of that family. I want to take a minute just to sort of maybe put a little bit of a different spin on what our conversation is about today. About 40-some years ago, there was a phrase that was coined called trading custody for care. And basically, when we speak of abandonment, and that actually is a very different population of parents, families, kids than I think we're actually hoping to support through the work that you all do, in addition to the work that's done by the state. My experience has been in working with several hundred families over 20 years. I can probably count on one hand the number of families who did not want their children. The amazing thing about parents and what led me to become a foster parent is parents will do whatever they have to do to make sure that their kids are safe and healthy. And I think at the end of the day, that's all parents really want for their children. I think that shifting the conversation around the abandonment that we are very much aware of and really focusing in on trading custody for care, because at the end of the day, that is actually what is taking place. Parents are told by hospital staff, state employee staff, the professionals they turn to seeking for guidance, saying, well, if you want your kid to get services, you have to give them to the state. We know that is not true. That is the absolute opposite of what needs to happen, because what we know to be true is child welfare is a system designed to address abuse and neglect. As you've had your speakers on the 15th and today sharing in their information, is that's actually not what's happening. These are families that have tried to navigate large state systems without really an understanding of what that particular state system does, what's their responsibility, who would be the person that I would contact at that state office to get assistance, right? So families struggle with figuring out, where do I even begin this conversation? 20 years of working with families and children, I've had a lot of conversations with psychiatrists, psychologists, pediatricians, neurologists, you name it, through the various hospitals throughout the state. And a lot of it keeps coming back to the same story of, we don't know who to connect these families to when they present in our emergency rooms and in our medical hospitals. One of the things that I learned in starting this work 20 years ago, and this has stuck with me ever since, and I'm not sure at what point, if ever, I will get past this. Every day in the state of Georgia, a child with a behavioral and/or developmental disability is given over to child welfare because parents cannot address the child's behaviors. So there is actually a category within information that is reported to the federal government about why children enter care. In the state of Georgia, and in the research that I've done over the last 2 decades, again, on average, 1 child a day because of the child's behaviors. And to me, that means a family that was unable to access the resources to meet the needs of that child, get that whatever it is that child needs in place. And how do we set these kids up for not only receiving support through early intervention, but then what does that look like as they move through their school years, as they move towards young adulthood? I am a firm believer that the earlier we get in there and intervene, and the longer we stay engaged in understanding that kids are going to continue to grow and development changes, as we know. So there's going to have to be a different approach at a different age, depending on where that child is at developmentally. Again, all of the work that I've done with families, particularly in my work around deflecting families raising kids with disabilities who were considering the trading custody for care so that their children can get services, it's always been the same. Again, like I said a few minutes ago, I don't know who to call. Every time I call this office, I'm directed to a different office. I call that office. In the meantime, mom is going to work. Mom is attending therapy appointments. Mom is attending medical appointments. Mom is trying to schedule medical appointments and therapeutic services, again, all throughout her workday while she's trying to work. In addition to that, she has the school system calling, saying, Mary's having a bad day today, come pick her up. Even though we try to advocate to parents to say, this is the school's responsibility. Where is the behavior plan? Where is the safety plan? Where is the crisis plan? Those don't exist. Kids go into crisis at school. Mom and dad get contacted. How many times can mom leave her job before there will no longer be a job to come back to? In 2016, in the state of Georgia, 48.9% of parents raising children that had complicated behavioral and or developmental disability services either left the workforce completely or had to reduce their work hours. So you can imagine the devastating impact to a family family when you lose half of your family's income. Then think about those single parents where there's not another parent present in the home. So now you have two people, a child with a disability, a parent who just wants the best things in life for her kid, coming out of the workforce because she's going to have to coordinate and try to figure out who the people are that her child needs to have access to. Then she needs to communicate that to her pediatricians and medical specialists so they understand the letters of medical necessity that need to be written and how specific those need to be in order to not be denied once presented to Alliant Health Systems or the Department of Community Health for approval of that service. The thing about all of this that breaks my heart is the majority of these kids, again, one child a day entering the system, do not exit until age 21. And that is horrifying, not only for children who no longer feel like they fit anywhere or that there's anybody out there that is on their side. Too many times they cycle through institutional settings, starting at, having the police called because there's a behavioral crisis. Police respond, the kids are arrested, taken to jail, or they're transported to a hospital, an emergency room, where they can begin the process of accessing services. Again, unfortunately, this is not a new scenario. This data and the research on this dates back until the 80s. So that just helps us sort of keep in mind that this has been an ever-present program. What are professionals saying? Mental health professionals from around the country, most importantly here in Georgia, what are we hearing about this trading custody for care? The words most often repeated are tragic, heart-wrenching, inhumane, and what I would offer is the bottom line is an act of desperation. An act of desperation when your child is telling you that he or she no longer wants to be alive, and this child is 7 years old. What is our response to that? How does a parent respond to that? I can't imagine the devastation. So that ends up becoming a situation where we become over-reliant on emergency rooms for behavioral health crisis care, right? We see the same thing with law enforcement. Far too often, police are contacted when there is a circumstance where there's a behavioral crisis in a home. I hear this more about when families live in apartment settings or condo settings or townhome settings where they have walls with shared neighbors. The child goes into crisis, the police get called, the family gets evicted. So now I have a family who mom was working, lost her job, trying to care for her son or daughter at home, keeping them safe and healthy, as well as their siblings, right? Because what we do know is mental health and developmental disability, the impact of those disabilities ripples through the family. It is not just, the parent that experienced this, siblings experience it as well. And it's oftentimes devastating for them because this may be their little brother or sister, or perhaps the big brother that they looked up to, and now they can't understand what's going on and why are they no longer living with us? Where is my brother? Again, what I hear from emergency rooms and law enforcement is the reason that these kids keep cycling in and out of these hospitals and in and out of these psychiatric residential treatment facilities is because of the lack of discharge planning. There are state and federal regulations that dictate with psychiatric residential treatment facilities, PRTFs, that actually explain what their obligations are when they're starting to begin discharge process for a child that was admitted to a facility for treatment. Interestingly enough, discharge planning starts the day of admission. That is best practice. And then you modify that plan as you spend more time with that child. They develop a trust in you. You've got more time to establish a rapport, right? The other piece of it is the extended admission. So oftentimes we hear about, and I know this for a fact because of the work that I do, is kids that are in foster care as a result of trading custody for care, still not having access to the home and community-based mental and behavioral and developmental services that they need. And they end up in these facilities for 2 to 3 years. We are not talking about months. These facilities were set up to provide services for a period of time. They were never designed to be a long-term setting. And the reason for that being is all the research that we've ever read about child development, and this research still continues to this day, is the longer the child is in a congregate segregated setting, the more globally delayed they become. Right? So it's a building full of kids experiencing the same types of behavioral crises or mental health labels. It's exhibited very differently, right? Because we're all unique people and that all comes out of us differently, particularly if we don't have the words to explain to someone I'm frustrated or I'm hurt or I'm angry, right? So what we see is kids are coming out of these long-term stays requiring more services than when they went in, which again goes back to my point about early intervention. Everything we know to be true is the earlier you intervene and you wrap that family with support and services that take a holistic approach to the family, right? What are the needs of the family in addition to this child? What are the needs of the sibling who may have witnessed some property destruction that occurred in the home during a behavioral crisis that they don't understand how to process, right? Another piece of that is when facilities do not do effective discharge planning, and the beautiful thing about our state policies is the facilities do not get to bill for the day of discharge. And that is purposeful because that is the day that your home and community-based service providers should begin services. So state and federal policy do require that children not be referred, but enrolled in services. That prevents a lapse. What we know to be true is when children are discharged home from facility settings without services in place, even with me working directly with the family, still can take 90 to 120 days for services to be identified, approved, staff trained, and implementation. So what we see in that time frame as parents are trying to navigate these systems to get these professionals that they've been given these phone numbers to, oftentimes to call to be told, I don't know why you're calling us. We don't do this service. We don't serve children. You know, the acuity is too much for us. The acuity is not high enough for us, right? The variety of things that we encounter. But again, with the kids that we've seen where there's been robust discharge planning, where providers know 30 days from discharge, we are up. It is up to us to help this child transition back home, safe, healthy, everybody moves forward, the family is healthier, we see parents re-engage with the workforce. It is all about successful discharge planning. And it has to be with intention, right? With the understanding, as you've heard many folks talk about, the cultural piece. That has to be a part of it. There also has to be some thought given to, again, the developmental age of the children. Do they have the words to communicate to you what's going on? One of my favorite things is play therapy, especially for the little ones, because they don't have words to tell you what's going on, but they can absolutely show you just through play activities. I've worked with many kids. There's certain kids that will always, which you've heard from your other speakers, that get into our heart and our soul. And there's been several kids that I've worked with. I started off when they were not even school age yet and still have relationships with them now. Simply because the family did everything that it could to not only build the natural support system within their own family, but then supplementing that with services from, community providers as needed. Another thing about the facility piece is, and I think I touched on this briefly, is the skills that are taught during the admission to the psychiatric residential treatment facilities don't always translate well back home, right? Because facility settings by nature are structured, routine, everything happens in a timely manner. Life does not work that way, particularly if you have younger siblings, you know, because oftentimes they require a lot of mom and dad's attention, and understandably so. But when I've worked with a child who within 1 year has experienced 22 placements within hotels, DFACS offices, jails, CCIs, child care institutions, you know, sort of runs the gamut, they oftentimes lose who they are and don't know where they belong. And that adds additional layers of trauma that you then have to peel back just to get to the core of what even got this started for this child as a youngster. I've worked with kids that have lived in PRTFs for 2 to 3 years, psychiatric residential treatment facilities, my apologies. They may not, again, through this global delay that we see that happens, the longer that the kids are within the facility settings, they don't have the age-appropriate cognitive skills to process what is going on around them. There's a lot of, sadly, peer-on-peer sexual assault that occurs within the facilities, deaths that happen due to chemical restraints, physical restraints, the things that we know need to always be last alternatives. And with the recognition of, it's challenging to be standing in a PRTF and see an 8-year-old go into crisis and then have 5 adults who are 2 feet taller than me descend on this kid and go into a physical restraint. And it's the look on the child's face that when you leave, you can't forget, because the fear and the terror is so real for them. Broader implications, and something that I think is absolutely critical for us to keep in mind, and I've talked about this briefly, is families having to exit the workforce. That, to me, is one of the danger signs when I'm working with families, because what that tells me is the family is now socially isolated, right? Parents stop going to Target and bringing their kids. Parents stop going to community events and bringing their kids. All of these types of activities that many families enjoyed just through their recreation, leisure, and participating in community events, school events, so much of this is no longer available to them and their siblings. So it's not only a child that is in crisis because of an unmet behavioral health or developmental disability need, but it's also the impact on that child's siblings, that child's parent, that child's community. Kids want to know when they have friends. Johnny lives next door to me. We've been friends for years, and now he's gone, and I have no idea where he went, And oftentimes we have, the last time I did a data check, because of the Georgia Advocacy Office and our Access Authority, I am afforded access to information that, while I cannot release it, I can utilize it in the work that we do to help share information. And again, going back to the exiting of the workforce. So I don't want to take up too much time. I just wanted to sort of share with you some of my experience just as a social worker who spends a lot of time with families, with kids, getting to understand who people are, and sort of helping create a sense of community around them so that kids do feel included, kids don't feel different, right? Being in special education classes in and of itself sets kids apart and creates a we-them type of conversation, which is problematic because kids at that age don't care. This is more of an adult thing where we attach labels and start this. But kids are really, really amazing because they can recognize that the child next to them may be experiencing some sort of dysregulation, getting antsy and unable to sit down. And just through those peer-to-peer interactions like Sue has mentioned, that is critical to these kids to know that they are not alone. Because as we know, there is a stigma that comes along with with behavioral health and developmental disabilities, and we don't want that to define who our kids are, because at the end of the day, we all as parents recognize the gifts and talents that our kids have, no matter how intense a home situation may be, and no matter how burned out a parent is after 13 years of trying to do this. The first thing I always ask them is, what about your kid makes you smile when you think about them? And that is when you learn who children are, because parents, no matter how bad things may be behaviorally, I've had parents, that have found knives hidden in their cars because their kids have, had intentions of doing harm to them. Putting that aside, I have the most artistic child. My kid is so creative, loves to read, loves to care for others. So we know who is inside these little people and these young adults, and it's up to us to make sure that we're providing them the tools so that they can go on and become the young, productive people we know they can be. They can get jobs. I'm a firm believer in, regardless of disability and the impact of that disability, employment is always an option. And school is always an option. And as we think about our own lives, those are huge parts of who we are. You go to a party or an event, you meet new people, what do you ask? What type of work do you do? Right? Or you ask a child, what school do you go to? What classes do you have? So I hope this information is helpful. I know this is a little bit of a twist on the language as I sort of sit in the abandonment versus trading custody for care, because while I know there is policy and statute that defines abandonment, what I know to be true in my heart and the people that I interact with every day is parents do not want to abandon their kids. They don't. They call and they cry every day. Bless you. And that further impacts their mental health, right? So it is about the holistic approach to a family, putting kids first, and the recognition of it does take a village to raise a child. So thank you much. Any questions, I'm happy to entertain. If it's information I don't have readily available, I will get that to you. Amber has been an amazing point of contact for me. I thank you so much.
Are there any questions or comments? Not seeing any. Oh, wait, got one.
Yes, sir.
Rosa Crawford.
Thank you, Madam Chair, and thank you for your presentation. During your presentation, you mentioned some of the interactions that you and others have had with children in schools and the challenges that have been presented with students.
Yes.
I wanted to know if there is, and I think it's safe to assume that a lot of parents don't understand what resources are available to them for their children. Is there any type of mechanism, any type of strategy that you think would be helpful so that all school boards will understand, I think, first, what type of resources that there are? Maybe that can help.
Right, absolutely. So one thing I would offer is and as you're already familiar, one of the most critical tools for children that are in the school system, particularly for children that experience developmental and or psychiatric disabilities, is the individualized education plan, because that is the plan that is utilized to help see the progress that the child is making during their education. Another thing that a lot of folks don't know is that school systems rely heavily on Medicaid to fund the services that happen within their school or that are needed within the school for that particular child. while a lot of that should be covered under the Individuals with Disabilities Education Act, there is a role for Medicaid in covering that, and schools do utilize that. One of the things I think that I would offer is that there has to be more of a commitment and a connection between public school systems and outside service providers that are providing therapeutic services to children. And I realize that is tricky because schools have to have policies in place for the protection of all students. But what we see far too often is the child's school day and the behavioral supports provided or perhaps not provided during that school day look very different than what is happening at home. And when children don't have that continuity of care and that consistency of language, that is oftentimes where they'll sort of get lost, right? Because the messaging that you get at school around behaviors and how we act and what are boundaries need to be the same language that's used in the home and community-based service providers that are stepping in when the child comes home from school that day. And that is oftentimes not the case. And that creates frustration for the kids because of confusion. So one of the things I would offer on that is it really does need to be a holistic approach. I recognize the education system has boundaries that it has to work in, but I would offer there must be some flexibility somewhere in there where this can be a team effort where kids are getting consistent messaging at home and at school. In addition to that, one of the things that keeps me up at night are the number of kids that are arrested at school. And I'm not talking high school kids and I'm not talking middle school kids, I'm talking elementary school kids. And seeing an 8-year-old being taken out of a classroom in handcuffs, I would offer is life-changing not only for that child who is experiencing, I don't even know what you call that, just the trauma and the humiliation and the confusion. But then also, what is the messages to the other students that are witnessing this with this going on? And what I find out is schools go to 911 without understanding that the crisis system is actually responsible for responding to crises regardless as to where it occurs: home, community, school. So, I'm always a little anxious about law enforcement intervening in these situations, particularly if you're a child that has a lot of sensory sensitivities. Someone coming into your classroom who you don't know, putting you in handcuffs, escorting you out of the building, putting you in the back of a police car, I cannot imagine what is going through that child's head, where I would offer a crisis system that responds with educated social workers, psychologists, behavioral folks who understand how to de-escalate a situation, which sometimes is simply just stepping out of the room for 10 minutes until the kids have a chance to just breathe and regroup and pull it together. I can remember my years in elementary school, which now are going back to the 60s, is recess was a huge thing. And that was a beautiful thing because kids got out, exercised, burned off energy, returned to the classroom, anxiety was relieved, and they were back in the frame of mind to learn. So I know that's kind of a long-winded question or answer. I apologize for that. But I think what I'm getting to is the systems cannot be fragmented. We've got to step back from the siloing, because when we have the siloing of service systems, that is where confusion comes. That is where services don't get applied for or approved. And then again, how do we make sure that what's occurring at home can be supported in the school and vice versa?
And may I have a very brief follow-up? And I appreciate your response. What I'm thinking of, Madam Chair, is some time ago you actually had a bill, and I think a holistic approach is kind of what you did with your 1183 with making sure that the Department of Education and the Department of Public Health work together for communication, so at least students, guardians, parents will know what services are available. And it sounds like there's an opportunity for that as it pertains to mental health services for our students.
Absolutely. And it's not only what services are available, but it's who I call. The most common discharge plan I see is a list of 10 phone numbers handed to a parent who is getting ready to bring a child across the threshold of the facility into the parking lot. You would be you probably wouldn't be surprised how many times we lose kids in that door-to-door transition. They exit the facility door, and before mom can unlock the car door, they are down the street, right? So it is definitely, to your point, that is absolutely critical. But families also need to know who it is. You know, who do I call? What do they offer? Am I getting a referral that is not going to just be a dead referral? It's so disheartening for families to be given the contact information of a professional just to call and find out that your child has this specific disability, and because of that, we're not able to serve them. Or they're, again, not acute enough. Thank you.
Now, it has always been a challenge to get coordinated services for all children, but especially those with any special needs. So I think we're highlighting some things in this conversation, the meeting today, that will go even beyond the issue that we're particularly focused on. I think there's some bigger things to do.
Absolutely.
I thank you for the folder that you gave all of us. I want to just, on a personal note, let all of y'all know that this precious little child that's in there, this is a great story to read and hear. She is a miracle.
Yes.
She's from Rome, Georgia. Her parents are there. They are friends, and I see them. And Ivy, probably, she's way outkicked what was thought would happen at first. And she is almost 20, I believe, now.
Yes.
But when you read it, you'll see she was born without a lot of things that we all take for granted.
Yes.
And still today is doing so well because of all of the supports that came around. And while hers would not be diagnosed as a mental illness necessarily, certainly huge physical challenges, and her parents, because I think of all that they have wrapped around each other and all that my community has helped them with, are also doing quite well.
Yes. And quick note, I forgot that Ivy came from your district, so that was in no way intentional. I guess
I just opened that book up, and every time I say that, because the book was printed a few years ago, I think.
Yes.
I think it refers to her being 7 in here. But this is a family who went to the wall for years and still does.
Absolutely.
To make sure that she gets everything that she possibly can.
I shared those booklets with you. Those are through the Children's Freedom Initiative and the work that we do with the University of Georgia, Georgia State University, and the Georgia Council on Developmental Disabilities. Every child in those books has a different story, but I think the loveliness of those books is how those stories are told, because it speaks to strength and opportunity and positivity, which so many families need to hear, because oftentimes things look, when you're inside of it, it looks dark and bleak, but we know it can be done, and these kids are great success. One young man, extreme psychiatric behavioral health support needs, goes on and joins the ROTC. This is a kid that no one ever expected to ever get out of school, let alone go on and become a part of the art. I mean, it just speaks to the strength of our kids when we give them the tools.
Sure. Well, thank you.
Thank you
for bringing everything to us today that you did. We've got some great information, y'all. There was a handout that you had here on the advocacy office that pretty much followed right along with what you were saying. And I just want to thank everybody. Are there any other comments or questions from the committee, for Mr. Sarah, or for anything today? Well, thank you all for hanging in. So this is our second. We will have one more. I believe the date of it is, I have it right here. When is it, Amber? October 22nd. We'll be wrapping up sort of the 3 meetings, and be ready to come out with some great recommendations, I think. So y'all have a great, safe trip home or to wherever you're going today. And to each of you that are still with us here today, too, or following along, I just hope everyone will continue to work. Just work for this, because we've got some great challenges ahead, but I think we're making a big difference so
And we're
far.
all in it together.
We are, for sure.
We
Thank
have
you.
the village.
Thank you. We are adjourned.
Thank you, Madam Chair.
Thank you. Go away.